This
if
conference will now be
any of
recorded.
our today's attendees, so speakers, students, or delegates could extend your support by checking the journals and will be interested in publishing an inaugural issue at any of the journals according to your area of expertise. We will also send an email with all the details about the journal after the commencement of the webinar. Do take your time and check that. Thank you. And before we start with the sessions, I guess some of you will be new to the GoToMeetings app. Let me just explain you the important tools required for the presentation. On the GoToMeetings app or web page, you can find four icons at the bottom center, that is mic, camera, screen, and the mic button. Click on that to mute and unmute. I request you all to stay muted while our speakers are presenting their research work so that it doesn't cause any disturbance to them. Camera, you can use this button to share or unshare the web camera. If you have the option to share the web camera, you can do it, and it is completely your choice. Screen, you can use this button to share your screen. This is the main part during your presentation. After I call your name from my side, I will be making you the presenter, and then only you'll be able to share your screen. So once I make you the presenter, you can click on the screen button and you will find a pop-up window to share your screen. And this is your fourth icon where you can use this to leave the session. On the top center, you can use the options to change your display settings. At the top right corner, you will have three icons: people, chat, and setting. In the chat option, you can chat with me or any other participants. Okay, without any further delay, let's move into the sessions. The first presentation is keynote presentation by Dr. Israel Yolis from Cal Health Services Israel. Hello, Dr. Israel Yolis. Are you ready with your presentation?
Yes, can you hear me?
Yes, you're audible.
Okay, thank you.
Okay, so I'm making you the presenter. Please click on the share button to share your screen. Yes, I made you the presenter. Please click on the share button
Okay,
to share your screen.
okay. Okay, do you see the presentation?
Yeah, it's perfect.
Okay, okay.
Please continue with your
Thank you.
presentation.
Thank you very much. It's my honor and pleasure to present our study regarding the association between 50-gram glucose challenge test results and the risk for future cardiometabolic morbidities. I have no conflict of interest to declare. Screening for gestational diabetes mellitus is universally recommended in all pregnancies. Screening is done either by one-step 75-gram oral glucose challenge test or by the two-step 50-gram glucose challenge test, the GCT. If GCT exceeds the institutional upper limit, a definite 100-gram OGTT is performed. As of today, GCT is only a screening tool in low-risk women to say whether to continue to 100-gram glucose challenge test or not. Values above 150 milligram per deciliter says go on to a 100-gram OGTT, and values below 150 milligram per deciliter are normal, and then you can continue the follow-up of the patient without any other recommendations. The aim of this study was to study the incidence of endometabolic and cardiovascular morbidities among women with GCT results within the normal range and also with very high GCT. So we looked at two arms of this study. One arm was GCT values within the normal range, and we look on later morbidities. And the second arm was looking at very high GCT values and later morbidities. So let's talk about the first arm. This was the population-based retrospective cohort study. It was performed in the Central District of Clalit Health Services. The study period was between 205 and 220, and the participants were pregnant women aged 70 to 55 who performed a GCT. This is the map of Israel. This is the central district. In Israel, there is a population of about 10 million people, and 5.5 million of them are insured in Clalit Health Services. In the central district, we have more than 600,000 insured people, and women aged 70 to 55 by 130,000. The study variables were the GCT results, and we divided it into groups: GCT below 120 milligram per deciliter, 120 to 29, 130 to 39, 140 and 149, and above 150. The endometabolic diseases were defined as pre-diabetes mellitus with hemoglobin A1C between 5.7 and 6.4, diabetes, and the definition was done either by the diagnosis in our medical charts or anti-diabetic drugs or hemoglobin A1C above 6.4, and hyperlipidemia we defined by the diagnosis in the medical chart or anti-hyperlipidemic drugs. Cardiovascular diseases was defined as hypertension, again by diagnosis or by drugs, ischemic heart disease by diagnosis, and vascular diseases were defined by diagnosis of CVA, coronary artery diseases, TIA, transient ischemic attack, or peripheral vascular disease. The results. We had about 53% of patients from our study population had GCT below 120, and these are the numbers of the other groups, and the intermediate group was 12.3%, and endometabolic diseases we found later in life in 70% of patients, and cardiovascular diseases in 3.2%. Now we wanted to see the connections, the association between these diseases and the GCT results. Regarding the background characteristic of the study population by GCT results, the maternal age was younger in the low GCT group than those with a higher GCT group. Born in Israel, again, were more in the low GCT group than in the high GCT group. Underweight were 6.2% in the low GCT and 2.3% in the high GCT, and obese women were 11% in the low GCT and 28.5% in the high GCT group. Now we looked at the association between the GCT categories and endometabolic morbidities later in life. You can see here with the blue line is the GCT below 120. The orange is 120 to 129. 130 to 139 is the gray. The yellow is 149, and above 150 is the light blue. And you can see in each variable that we looked, the higher the GCT was, the higher was the later morbidity. And if we look at the total endometabolic morbidities, we can see the difference between the groups. When we look at the association between GCT categories and cardiovascular morbidities, again, we found the same connection, the same association in hypertensive disease. There was slightly less in the ischemic heart disease and vascular diseases, and the total cardiovascular morbidities again showed the same association. And if we look, it was most prominent in the hypertensive diseases, where women with low GCT had less hypertensive diseases later in life. So the conclusions of this part of the study is that GCT between the 120 and 139 milligram per deciliter, which is actually normal GCT, but they have significant increased risk for endometabolic morbidity. And GCT of 120 to 139 were found later in life with a significant increased risk of hypertension. Possible mechanisms of this is that we know that in gestational diabetes mellitus and in diabetes, there are inflammatory processes in the vasculars of patients, and this produces endothelial damage and then cardiometabolic risks, and maybe even those values that are normal but are high in the high normal, maybe there is a similar association in this group and the later cardiometabolic diseases. And this study was published in the Archives of Obstetrics and Gynecology a few months ago. And the second arm of the study, we looked at the very high GCT values and later morbidities. GCT results above 180 or 200 milligram per deciliter are considered as diagnostic for gestational diabetes mellitus. There is no data on long-term endometabolic and cardiovascular morbidities in these women, looking only at the results of the GCT. The aim of the study was to study the incidence of endometabolic and cardiovascular morbidities among women with high, above 180, or very high, 200 milligram per deciliter GCT results, these 10 or 11 micromole per liter, respectively. Again, this was the same study group as before. There were pregnant women aged 70 to 55 who performed the GCT at the Central District of the Clalit Health Services. And the study population was divided into the following groups: high GCT and very high GCT. And the reference category was GCT below 120 milligram per deciliter. The endometabolic morbidities, again, were defined as prediabetes, type 2 diabetes, or impaired lipid profile, and cardiovascular morbidities, as I mentioned before, hypertensive disease, ischemic heart disease, or vascular diseases. There were 7,568 women that met the inclusion criteria. The mean follow-up for the endometabolic disease was 6.1 years, and for the cardiovascular diseases, 6.7 years. 3.9% of the population had high GCT between 180 and 199, and 2.5% had very high GCT above 200 milligram per deciliter. When we look at the reference group and wanted to see the differences for the 180 to 199 and to the 200 milligram groups, we could see that maternal age in the low group was significantly younger than the higher groups. We can see low socioeconomic status was higher in the high or very high in the high or very high GCT. Again, the BMI, we could see that women with the low GCT had lesser than 30.6% of women had BMI were obese. When we looked at the high group, it was 44.5%. When we looked at the incidence of endometabolic diseases, we saw that in low GCT there was 70%, compared to the high GCT 50%, and 73% of women with very high GCT had endometabolic diseases later in life. And when we looked at the adjusted hazard ratio for parity and BMI, we saw that the hazard ratio was 3.25 to the high GCT group and 5.26 to the very high GCT group. When we looked at the incidence of endometabolic diseases by BMI, we saw that this connection still remained in the low BMI group and also in the high, very high, in the high BMI group. There was association between the high and very high GCT and future endometabolic diseases, regardless the BMI of the patient. When we looked at the incidence of cardiovascular diseases, we saw that the women with low GCT had only 2% later on cardiovascular diseases, compared to 5.3 and 6.6 at the high and the very high GCT. Again, the adjusted hazard ratio was 2.13 to the high GCT group and 2 at the very high GCT group. When we looked at the BMI, low BMI and high BMI, we didn't find this connection in the low BMI, but we still find that that connection between low GCT, high GCT, and very high GCT, and later cardiovascular diseases. So the conclusions of this part of the study is that in low-risk women, high and very high 50-gram GCT results were associated with an increased risk for endometabolic and cardiovascular diseases later in life. Our study has several limitations. It was a retrospective study. There was no data on other confounders, such as, for example, smoking. And we know that cardiovascular morbidities develop usually later in life. Our follow-up was 6 years, and maybe later in life we could find more cardiovascular diseases. The strength of the study is that it was a very large cohort, and we have access to all diagnoses, to the laboratory results and prescriptions, because we have one database of the Clalit Health Services. And the conclusions of our two-arm study is that the higher GCT results within the normal range or very high results are associated with an increased risk for endometabolic and cardiovascular diseases. Currently, the GCT is only a screening tool for GDM diagnosis, but GCT's absolute value is a significant independent predictor of future cardiometabolic diseases. And today, when a patient enters my office and she had GCT of 134, I made an asterisk because I think, and I tell her that she has to take care of her future because she is in higher risk than women with low GCT. 50-gram GCT may assist in identifying women at high risk for future morbidities. I want to thank my colleagues for this study, to Dr. Tamar Weinstock for her meaningful and clever assistance, Dr. Adi Vinograd, Dr. Tzachit Simon Tuval, and Dr. Tovia Bayevsky. Thank you very much.
Thank you, Dr. Israel Yolis, for your wonderful presentation. Does anyone have any query? Hope there are no queries. Thank you once again, Dr.
Thank you very
Israel
much.
Yolis,
Thank
for
you.
your wonderful presentation. So, okay, let's move into the further presentations. The next is the oral presentation by Dr. Tamar Weinstock from Ben Gurion University of the Negev from Israel. Hello, Dr. Tamar. Are you ready with your presentation?
Yes, I am.
Okay, so I'm making you as a presenter. Please click on the share button to share your screen.
Can you see my screen now?
Yes, your screen is visible and it's perfect. Please continue with your presentation.
Okay. Hello, my name is Tamar Weinstock. Again, I'm from Ben Gurion University of the Negev in Israel, and I'm going to present the results of our study regarding success rates of single versus double in utero insemination procedure. I want to thank my colleagues, Dr. Israel Yolis, who just presented, and you see the other names who were collaborators. I'll give you some background on our question. Fertility is a problem that the rates of infertility worldwide are considered to be around 16%, which means 1 in every 6 couples are going to face infertility problems. The definition of infertility is not being able to conceive within 1 year of unprotected intercourse. Infertility and subfertility are global health issues affecting millions of people worldwide, and rates are increasing yearly. This is a new data I found from the WHO website. In Israel, the issue of fertility is of enormous social and cultural importance, as reflected in unprecedented rates of fertility treatment, and it's a public health funding policy. So what this means is that everyone in Israel pretty much is able to receive fertility treatments until they have 2 live children. Therefore, in Israel, Israel is a leader in the field of reproductive health and IVF treatments and research on this issue. And it's regardless of the socioeconomic status of the patients, because again, this is free and it's publicly available for all citizens. Our work is focusing on intrauterine insemination, or in short, IUI. It's relatively a simple procedure, and what it does, it's taking the sperm from the partner or the donor and putting it directly into the uterus, and it's considered the first or second step of treatment specifically for couples with unexplained infertility or with male infertility or mild cases of endometriosis or for unknown reasons. This is pretty much what they start out for the treatment. It's not invasive, it's safe, and the costs because of that are relatively low. What they do in the IUI procedure is, as we said, we enter they take the sperm and enter it into the uterus, and the timing is very critical because they obviously want to have to get the fertilization, so they have to make sure the sperm is entered, is available during the ovulation, which means that they can usually try to do the IUI around the LH surge to be available during ovulation. So if there's one IUI procedure, it's usually done on the 13th day. And if there's a double IUI, that means they would do another repeated procedure the following day. And around the world, there isn't clear evidence which one is better, if one procedure is enough, and if there's any sense to do another procedure. There are research from around the world, they show better outcomes after double IUI, and there are lots of research done that found actually that even that one is enough, and that the additional procedure doesn't add any or doesn't increase the percentage of pregnancies. Despite the different studies conducted over the years, no agreed conclusion was reached, and the clinician chooses the protocol for treatment based on their own beliefs and experience instead of research and evidence. So our aim was the main aim was to compare the success rates of single versus double IUI procedure among women undergoing fertility treatment. We also wanted to examine the effect of single versus double IUI on clinical pregnancy rates in different age groups, in younger women below the age of 35 and older above the age of 35, and also examine the effect of single versus double IUI on clinical pregnancy rates in different BMI groups. We were looking into women who are obese with BMI over 30 versus women who are normal or overweight. And we also looked into the incremental costs of a second IUI procedure as compared to a single one. As for the methods, we used retrospective information on a population of Coalesce Central District, which serves a population of about more than 500,000 patients. And the outcome we were looking for is obviously a pregnancy, which was based on positive beta HCG test, or if we didn't have the beta HCG available, then we looked into the time window within 24 to 28 weeks of gestation if a GCT test was performed. So obviously that meant she was pregnant, or according to birth reports following the treatment. For each cycle documented in a separate row in the data file, and every woman was labeled with a unique ID, allowing us to control not only for the treatment, but also for repeated treatments among the same patients. At the first step, we did univariable analyses. We compared women who had one and doubles IUI. And then we did some multivariable analyses. We used this generalized estimating equation multivariable analysis, which also allowed us to account for women actually having multiple treatments during the cohort. And eventually, as I mentioned, we also looked into the costs of adding an additional treatment. And these are our results. As first of all, you can see our sample size was very, very big. It's much larger than if you look into the, if you look into the literature, it's much larger than the bigger review papers and meta-analyses. What we see here is we have 11,000 women who had a single IUI treatment and almost 7,000 women who had double IUI. And we pretty much see differences in most of the background characteristics of these women. We see that women with double IUI were younger than the ones receiving only a single IUI. We see that they tended to be overweight, obese, or morbid obese, the women who received double IUI. We also see that their socioeconomic status was lower, and they were more likely to be exempt from paying for Social Security. And the last thing, they were less likely, to have a previous pregnancy. As for the treatment they received, we also compared that, and we saw that women who had a double IUI were more likely to have ovulation triggering, and they were more likely to, this is what we see up here. And additionally, we looked into whether or not the women got ovulation stimulation besides the ovulation triggering, and they had an option either to have a natural cycle or to have some support to increase the chances of having more than one ovum. So these women were actually at lower risk to have a natural cycle, and the women who got a single IUI were more likely to receive some support. And for the main results, what we see here is that women who had a single IUI had higher chances of having a pregnancy. And this difference was statistically significant, as we can see here. So the chances of having a pregnancy were 12% lower among women who had a double IUI as compared to the women who had a single IUI. We also looked into background characteristics who are associated with a pregnancy, with chances of having this pregnancy. And this is for identifying possible confounding variables or variables that we would like to adjust for in the multivariable analyses. So none of these are really surprising. We see that among women, older women, the rates are lower. Women suffering from obesity, again, the likelihood is lower. And we can see all these background characteristics we have adjusted for. And this is what we see in the multivariable analysis. Again, this is a general estimating equation, GE model, which adjusted for women showing more than once in the cohorts. What we see here is after adjusting for older maternal age, for BMI, for lower socioeconomic status, and for prior treatment, ovulation, triggering, and stimulation, ovarian stimulation, we see that still the risk for, or the chances for having a pregnancy were actually lower among women who had a double IUI as compared to a single IUI. So, and if we saw before a 12% reduction, now we see even 13% reduction after adjusting for all these covariables. As I mentioned before, one of our aims was also to look at different BMI groups and different age groups as well. So among women who are lower or younger than 35 years as compared to mothers who were older than 35 years old, we saw that the effect of a double versus a single IUI was much larger among older moms, meaning that older moms would benefit more from a single IUI as compared to younger moms. And actually, this association was not even significant among the younger mothers. Still, it was in the same direction, meaning the risk was lower, the chances were lower among the double IUI, but still this was not significant. So older moms would benefit from a single IUI as compared to double IUI. When we were looking into obesity or mothers suffering from obesity, again, these are the obese mom, we see them here, and the non-obese or overweight and normal weight. And we see here the association was pretty much similar, and the risk was, the chances were about 13% lower among the double IUI group, but these results were not significant among the mothers with a BMI over 30. Again, same direction, but these were not significant, but they were significant, meaning mothers with BMI below 30 would benefit more from a single versus double IUI. And another stratification we did is by the natural cycle or whether or not they receive another additional support for ovulation triggering. And we saw that the risk, the chances of having a pregnancy were lower among the moms who conceived naturally or having received clomiphene citrate. And as for the cost analyses, if we do add another cycle, another treatment, meaning the double versus the single IUI, the cost would be 1,036, 1,300 new Israeli shekel per each cycle, and that's for one woman. So for 1 year, the reduction would be around close to 400,000 new Israeli shekel per year that we can actually save if we do not do the double IUI. As for the limitation, the data does not include etiology of infertility, preventing inference regarding specific indication that may benefit from choosing one or the single or double IUI treatment. For instance, we didn't have the partner's age, semen quality, and the source of semen, whether it was the partner or donor. This data was missing, so we weren't able to account for these characteristics. So So in conclusion, we found that the single IUI protocol treatment is superior to double IUI in this study population. The superiority of this protocol over a double IUI is significant among women who are aged 35 years and older, and women with normal or overweight, normal BMI or overweight, and women undergoing IUI treatment without adding ovarian stimulation by gonadotropins. Using double IUI carries incremental cost of approximately 400,000 new Israeli shekel per year. You know, we're from Israel and there's a war going on here, so I couldn't just ignore it and not say anything about our 240 hostages who were kidnapped and are now in Gaza, and we really should do anything we can to bring them home. I want to thank you all for listening.
Thank you, Dr. Tamar, for your wonderful presentation. Does anyone have any query?
Hello. Hello. Anybody hear me?
Yes.
Yes, yes.
Hello, Dr. Tamar. Thank you for your nice presentation.
Thank you.
I'm Dr. Suzanne Sharqawi from Alexandria University, Egypt.
Hi.
I'm having just a question. About your last slide.
Yes.
I want to ask you, what do you suppose that we should do to release these hostages?
First of all, I want to, of course, we cannot do anything, but we can do everything we can to raise awareness to the situation. And I wish people would see and agree with Israel and feel it's legitimate to fight until our hostages are back home. And
But
that we
I
have
think
all
it
rights
have been 40 days now fighting, and
That's right.
you didn't save a single hostage. Do you think maybe it's time now to take a different strategy and stop killing civilians and try to negotiate to release the hostages?
Well, I think they're working on that in parallel, but actually what we think is that first we have to get our hostages back and then we can talk. We cannot talk with people who are holding 240 civilians, babies, mothers, grandchildren, and their grandparents, and we cannot negotiate with them.
Yes, but
First, we
I
want to see
think
them
there is
home, and then we can talk.
nothing happened since the war started except killing civilians. As I am a professor of infertility, and my hope is always getting a family, a little child. Actually, these photos of the killed babies and the newborns without incubators actually makes me very sick, and I don't get the point about all this thing happening. Yani, how it could be helpful to kill people to release other people, but I didn't think the army
Israelis.
succeeded till now to release a single hostage. So
Well,
I didn't
our
get the
army
point.
is looking for the hostage. Our army is looking for the hostages. And let me remind you that we've been under fire for the last 18 years. And the only reason our civilians are not killed is because we used our money to protect ourselves and to have the shields that are protecting us from the rocket attacks, the constant rocket attacks that have started over 20 years ago. So the reason the reason civilians are killed in Gaza is because the Hamas uses the civilians in Gaza as human shields, and
Hello.
they don't
Dr.
let
Tamar,
them.
I think this
Hello.
this
Hello,
this
everybody.
statement, okay,
Hello,
hello, but
everyone.
this statement is
Yes,
just
sorry for the
so
interruption, but
consumed now. You have to change the statement to
hello,
try to find another cause for this
hello, everyone.
tragedy
Yes,
happening in Gaza. Okay, thank you.
the tragedy is in Israel. I'm sorry, I do not agree with you.
Hello. I don't think this is the right platform to discuss about this. If anyone have any questions regarding the presentations, they can ask, but not about anything else. And I hope there are no more questions regarding the presentation. So let's move forward with the further presentation. The next presentation is by Dr. V.S. Harita from Government 3D Medical College from India. Hello, Dr. Harita. Are you ready with your presentation?
Yeah, good evening. I am ready, but then how do I share my screen? Can you just let me
Yeah,
know that, please?
I'll give the permission, then only you will be able to share your screen. So I made you the presenter.
Yeah,
Please click on the share button to share your screen. Yes, your screen is visible.
okay.
Please make it a full screen and start your presentation.
Yeah, so it's the presentation visible?
Yes, your
Yeah,
presentation is visible.
okay.
Please make it a full screen. Please make
I
it a
think I've
full screen.
already, yeah, actually, I think I've already made it a full screen, so is it still the,
No, please click on the slideshow option at the bottom right corner, the fourth icon. Yeah,
yeah,
that one.
so is it right now?
No, not yet.
Uh, is it okay now, or should I, yeah,
No, it's not full screen yet. Okay, stop share your screen and please follow my instructions.
okay. Uh, okay, just a second. Okay. Uh,
Now,
yeah,
hello. Now click on the share
hello.
button. Now click on the share button. As soon as you click
Okay,
on the share button, you can find a pop-up window which shows Windows entire screen and screen. So please select the entire screen option.
okay,
After selecting that, please give access to the audio.
okay.
Yeah, after that, please open your PPT.
Okay, is it?
But no, your screen is not visible yet.
Just one second. Entire screen. Okay, just a second.
Yeah. Yes, your screen is now visible. Please open your PPT now.
Yeah. Is it?
Yeah, it's perfect. Please continue with your presentation. It's perfect.
Okay, thank you so much. So good evening, all. Okay, my presentation is titled Consolidation Chemotherapy in Locally Advanced Cervical Cancer as a Time to Think Beyond. So this topic is basically based on one of the studies done by me, that is integration of consolidation chemotherapy in locally advanced cervical cancer. Now, why this topic came up is that because of the background of cervical cancer in India per se. So before we move on to that, we should know globally what is the problem that is still there. So in the global scenario, cervical cancer is a global health problem in women, as we all know. Globally, it still continues to be the most common cancer in females, being the fourth most common after breast, colorectal, and lung cancer. Now, uterine cervical cancer is one of the most prevalent neoplasms among women in the developing world, and as you can see, among all the if you when among females, including all ages, as we can see, the new cases being registered according to the Globocon 2020 data is cervical cancer still constitutes 6.5% of all the cancer cases being reported in women. Now, in these diagrams, I want you to know that in 2020, the Globocon 2020 data says that among all the cases being recorded in including both the sexes and all ages, cervical cancer constituted 3%, around 3% of all the cases, and around 3% of all the deaths being reported. Now, when you come to the Asian continent per se, as you can see in the below images, that Asian continent still contributes majority of the cases in incidence and prevalence. When you measure incidence as well as prevalence, Asian continent still contributes more than 50% of all the cases of cervical cancer. South Central Asia, where my country belong, India, in females, according to the 2020 data, the cervical cancer constitutes 15% of all the cases being reported, and when it comes to both the sexes, it still constitutes 8% of all. Now, the Indian scenario, Globocon 2020 data says that in India, in terms of incidence, breast cancer is followed by oral cavity cancers, followed by cervix, followed by lung and colorectal. And cervix cancer constitutes around 10%, 9.4% of all the cases. Now, why do we have to discuss this? Is because it is still a major health problem being faced by Indian women, and every year approximately 1.2 lakh women develop this disease. In India, the incidence of cervical CA varies from 13 to 24 among 1 lakh women per year, and in rural areas, it continues to be still highly prevalent. It is estimated that cervical cancer will occur in approximately 1 in 53 Indian women during their lifetime, compared to 1 in 100 in the more developed regions in the world. And there are approximately 3 lakh deaths due to cervical cancer worldwide in 2020. And cervical cancer accounts for 11.4% of the total number of deaths due to due to the cancer in India. Now, is prevention possible or no? Like, as we all know, 10 to 20 years of the natural history of progression make cervical CNEs early preventable disease, and there provides a rationale for screening. How do we do the screening? We can do it either by the regular cytological examination or by HPV testing. Now, literacy, awareness, socioeconomic status, personal hygiene, early marriage, multiple pregnancy plays an important role in this. And therefore, and these all factors are considered to be when it is like less literacy, less awareness, poor socioeconomic status, poor personal hygiene. They are the risk factors for the disease. Now, three prophylactic HPV vaccines are annually available, where a bivalent, a quadrivalent, and a nonavalent targeting all these strains of HPV are available. But the coverage of it we need to discuss on. Now, the higher proportion of locally advanced cases, that is the another issue. Like, there are still regions reporting higher incidence of locally advanced cases in India. Now, the outcome depending on the stage. Now, what is the outcome according to the stage? Early stages of cervical CA. Early stage means stage till 2A. The main treatment is radical surgery or primary radiation depending on the patient's general condition. And locally advanced cases which includes a stage 2B and above, radiation therapy has been the main treatment option for locally advanced cervical cancer since the discovery of radiation. Now, the treatment in cervical CA, how did the whole thing evolve? Was that it was initially an external beam EBRT, which means external beam radiation alone. Then came up external beam radiation along with brachytherapy, and then which came up to the current standard, that is combined radiation external beam plus brachy with concurrent chemoradiation, that is chemotherapy being given along with radiation. If intracavitary is feasible, we do intracavitary. If not intracavitary, then we go ahead with interstitial brachytherapy. It's said that the total treatment time should be completed within 8 weeks. That is because a time exceeding 9 to 10 weeks, it is associated with a poor prognosis in the treatment outcome. So, what is the current standard for a locally advanced cervical cancer treatment? Is chemotherapy administered concurrently with radiation, that's called concurrent chemo RT in locally advanced cervical CA, And this current standard came up after the results of the 5 landmark trials in cervical CA in radiation and locally advanced cervical cancer, that is Whitney et al., Eiffel et al., Rose, Peters, and Keys. These studies demonstrated that concurrent chemoradiation has a significant survival advantage of around 10 to 15% at 5 years after treatment compared with RT alone. According to the literature, now, the incidence of lymph node involvement increases with as the FIGO stage increases, and lymph node mets is considered to be a most significant prognostic factor in cervical cancer. Now, according to the literature, the incidence of lymph node involvement it increases as the stage moves ahead, as I said. And if you want, if you need to know the percentage, it occurs in around 12 to 20% in stage 1B, and as you can see, as it reaches stage 2B, it's around 30 to 40%. The 5-year survival rate after treatment in locally advanced cervical cancer it varies from 50 to 60 in stage 2B and going to around 5 to 15 for a stage 4A disease, which means that 30 to 50% patients still develop treatment failure. Now, locoregional recurrence is the main cause of failure. Local control is becoming a reality in locally advanced cases, but then the distal control is still a major issue. Distant relapses they range from 7 to 11% for a lower stage compared to 16 to 22% when it comes to a higher stage. Concomitant chemotherapy and radiation, that is, chemotherapy along with radiation, has improved tumor control and overall survival, as I said before, but then this benefit is maximally seen in early stage diseases. According to the RTOG 9001 trial, the concurrent chemoradiation did not reduce a para-aortic recurrence, and that more than 50% patients with a para-aortic recurrence revealed distant metastasis after concurrent chemotherapy. And there is no standard treatment existing till date for cervical cancer with lymphadenopathy after concurrent chemotherapy. The ability of radiotherapy to cure a locally advanced case is limited by the size of the tumor because most of the patients in a locally advanced stage have a larger tumors. So we need to put in efforts to maximize the local control as well as to improve the survival and quality of life in cervical cancer patients. In the last 7 years, the use of systemic chemotherapy prior and beyond concurrent chemoradiation has been studied as a treatment intensification strategy. As re-radiation of a previously irradiated patient, we need to consider re-radiation with extreme caution. 2008 meta-analysis in 2008, it's of many trials strongly suggested that an addition of consolidation chemotherapy was beneficial. And keeping this background in mind, we came up with a hypothesis that is, in the application of consolidation chemotherapy to definitive treatment in patients with locally advanced cervical cancer was better. The aims and objectives of our study was to evaluate the efficacy, the toxicity, and to evaluate the tumor response and the locoregional control following consolidation chemotherapy. The materials and method of my study was all of the patients included were of a locally advanced cervical CA, included from stage 2B to 4A. They were randomly selected, divided into two groups with a minimum of 30 patients in each group. And the criteria was random of putting the patients in both the groups, and all the patients were a proven case of cancer cervix. Sample size was calculated using the statistical software EpiInfo 2000, and the data is being presented either as mean or standard deviation. And in order to get the maximum sample size, we had screened all the patients who fulfilled the criteria and who gave their consent. The statistical analysis was done using SPSS version 20. Univariate and bivariate analysis of the data was done, and all the means were the results were expressed as mean or standard deviation or as percentages, and the p-value of less than 0.05 was considered significant. The criteria used, the inclusion criteria included, we included any patient more than 18 years and less than 70 years with a proven case of malignancy of cervix being of a locally advanced stage with a performance status of KPS at least 40 and ECOG of at least of 2, and with a normal cardiovascular function and with normal counts and blood chemistries, and any patient who was less than 18 and more than 70 with uncontrolled morbidities and who had already received a treatment in form of chemo or radiation, or if KPS of less than had a performance status of with KPS score less than 40 or ECOG more than 2, and who were pregnant or who were lactating and who had a history of distant metastasis or any other synchronous malignancy were excluded. The RT radiation technique in the schedule we used were technique external beam radiation was given using a Coalesce therapy machine, and the intracavitary RT was given by an HDR brachytherapy technique. The schedule was through external beam. We had planned for a 50 gray in 25 fraction, with 2 gray per fraction, 5 fraction per week. The gap between external beam and intracavitary was kept as 1 week, and following which high dose rate brachytherapy was planned for 21 gray in 3 fraction to point A, with 7 gray being prescribed per fraction at point A, 1 fraction per week. The portals used were a parallel opposed anterior posterior field or a 4-field blocks technique. Concurrent chemotherapy was given, which was weekly cisplatin, 35 milligram per meter square along with radiation. Treatment flowchart, and this was our whole study flowchart, which was after getting enrolled in the study, the patients received radiation along with the brachy. After 3 to 5 weeks, they were scheduled to 2 arms, arm A and arm B. That is, arm A, the study arm patients got a chemotherapy, including taxane, paclitaxel, and carboplatin every 21 days for 3 cycles, and then kept on follow up. The results after the study was categorized into 3 categories: patient-related, disease-related, and toxicity-related. The patient-related factors, the parameters we took into consideration were these: the age. Most of our patients belong, as you can see, belong to a 41 to 50-year age group, with most of them being from a rural background and with an ECOG performance status of 1. And most of them belong to an upper lower socioeconomic class, and tobacco addiction was present in most of them. The histopathology, most of them had squamous cell CA in the as a histopathology with a grade 2 squamous cell carcinoma. In majority, it was seen in majority, and most of them had pelvic lymph nodes at the time of presentation. That is making stage 3C1 as the most common stage seen in our patients, and with a tumor size of less than 6 centimeters. The toxicity related characteristics, we had divided the toxicities into acute and late. Acute, we had analyzed graded using a CTCAA version 5, and late toxicities were graded using RTOG, late radiation morbidity scoring scheme. A grading was done between 1 to 4, where 1 was taken as mild and 4 as severe or life threatening toxicity. The renal toxicity we had assessed using the values of serum creat and blood urea levels, and as you can see, after the third cycle of consolidation chemo, a grade 2 serum creat values were seen in 4 out of 30 patients, which had settled down by the end of the third month follow up. And after the blood urea levels, 15 out of 30 patients had an abnormal urea level after the completion of third consolidation chemo, but then which had settled up by the third month of follow up. And hepatotoxicity was analyzed using total serum bilirubin levels, and grade 1 toxicity was seen after the only in 5 patients. Only it was seen in only 5 patients after the third consolidation chemo. Skin toxicity, consolidation chemo did not increase any the effect of radiation dermatitis being recorded in patients. And gastro GI toxicity was analyzed using by scoring nausea and vomiting, diarrhea. Nausea, a grade 3 nausea was seen after the third consolidation chemo in 16 of our patients, and vomiting, a grade 2 vomiting was seen in 16 of our patients after third consolidation chemo. And in 13 out of our 30 patients, a grade 2 diarrhea was seen after the third cycle. Hematological toxicity was assessed using anemia, leukopenia, and thrombocytopenia. A grade 3 anemia was seen after the third cycle in 11 out of 30 patients, and a grade 3 leukopenia in 2 out of 30 patients, and thrombocytopenia, grade 2 thrombocytopenia was recorded, and that was seen in 3 out of 30 patients. Genotoxicity was assessed using cystitis by grading cystitis, and uh, cystitis and the normal level of proctitis or rectovaginal mucositis. Consolidation chemo did not seem to increase any of the usual levels of cystitis or proctitis or even rectal and vaginal mucositis that is being reported. Peripheral neuropathy, yes, eight of our, out of our 30 patients had a grade 3 peripheral neuropathy after the third consolidation chemo, but then that was symptomatically managed, and none of them had it by the first month of follow up. The treatment response in the third month, almost 70% of the patients had a complete response, and progressive disease was seen in one of our study patient. So, with this, The conclusion was that the standard of care for locally advanced cervical cancer has been definitive concurrent chemoradiation. Although the survival with this has been found to be good, a large number of distant and local failure has been reported. Therefore, additional researches need to be done focused on the role of consolidation chemo after standard concurrent chemoradiation and intracavitary brachy is necessary. With the same, we have conducted the study, and to summarize our findings, the treatment response in terms of both local, regional, and distant control was better in the study group, and it was found to be statistically significant. So, a longer follow-up period is definitely required. Hematological toxicity was seen as moderate or severe anemia, leukopenia, and thrombocytopenia, mainly in the study group, but then it was symptomatically it could be managed. GI toxicities were more commonly seen in the study group. Peripheral neuropathy grade 2 and 3 was commonly seen in the study group, but it was conservatively managed and chemotherapy wasn't discontinued for any. Acute cystitis was equally present in both, and however, chronic cystitis and proctitis, the addition of consolidation chemo then seemed to increase the normal ranges that is being seen usually. Progressive disease was found in both the groups, but then it was mostly seen in the control group than in the study group, with most patients having local as well as distant recurrence. Based on these, we have concluded with this that addition of few cycles of consolidation chemotherapy with taxane and platin after a standard concurrent chemoradiation is beneficial in patients with locally advanced cervical cancer, with manageable toxicity and a good compliance. So these were the references which were used in this presentation. And thank you all for listening. If any questions or any doubts, I would like to take it.
Thank you, Dr. Harita, for your wonderful presentation. Does anyone have any query? Hope there are no queries. Let's move forward with the further presentations. The next
Yeah, thank you so
presentation
much.
is, thank you so much, Dr. Harita, for your wonderful presentation. So the next presentation is by Dr. Mohammed Hosni from Consultant London Northwest University Hospitals, United Kingdom. Hello, Dr. Mohammed Hosni. Are you ready with your presentation?
Hello, hi. Let me try to share it now.
Wait. Okay, I'm making you the presenter.
I just want to check how can I share it.
Yeah, please click on the share button to share your screen. Please click on the share button, and then you can find a pop-up window. Then you have to
It
select
doesn't
the
allow
entire
me.
screen. Yeah, I
Share
gave you the
button on the
permission.
presentation.
Yes, after that you have to click on the first click on the share button, and then
Okay.
click on the entire screen option. After that, you have to give access and then open your PPT.
Sorry, just a moment. So on share button doesn't allow me.
Now click on the share button. I gave you the permission.
Okay, just a moment. Let me. Okay, share button here.
Can I ask you a question while he's getting started? Is it possible just to share the program?
Hello, Dr. Ricky.
Hello.
Hello.
Okay, just a moment. Yeah. Share button. Yes. Just a moment. I find it now. Just a moment.
Yes, after that, click on the entire screen option
Yeah.
and then give access and then finally open your PPT.
Share screen. Yes. Okay, and
After that,
then
click on the. Did
entire
you
screen option,
find the
yes?
entire screen option? And then you have to give access, allow your audio.
Yeah, I did, yeah.
After that, open your PPT.
It's open. Can you see it now?
No, Dr. Mohammed, not yet.
Entire screen option, and then yeah, let me open now. Yeah, let me open now here. Can you see it now, or?
No, not yet.
Yeah, here. Yeah, I can see. Just a moment here. Please let me know when you can see it.
Okay, sure, but your screen is not shared yet.
It's not
It's
shared
not
yet.
shared yet.
Yeah.
Probably has that green green light around it, the green border.
Not quite sure how to entire screen share.
Yes, your screen is shared. Please open your PPT.
Here.
Yeah, please make it a full screen. Yeah, that's
Here.
perfect. Please continue with your presentation.
Okay. Good morning, everybody, and thank you for inviting me for this honorable conference. Mr. Mohammed Hosni, I'm a consultant, London Northwest University Hospital in London, United Kingdom. My presentation today will be about like a different subject from previous topics. I'm not quite sure how common it is, this subject, and I'm not quite sure if anybody. It's basically it's about rotational operative vaginal delivery, and whether anybody have ever performed this rotational delivery. Anybody have ever even observed it or been supervised? It's tricky, and it's not something even here in the UK we don't. Is not part of our usual practice, or we don't see it in every trust. It varies depending upon the experience of different consultant professionals, every trust. So that is basically the main topic of my presentation today, is about the art of keel and rotational forceps delivery. And do we need more training, or should we just stop it and just move on to a different methods of rotation, or go for cesarean section even? I think that's a question I'm trying to answer it today. This is my trust here it's in the northwest part of London. And that's why I discussed today about the background of my study and patient methods, results, limitation, discussion, and conclusion. I conduct this study in different trusts in the country, and I managed to pull the data, and I'll show you the results now. So basically, as we all know, malposition of the fetal head accounts for around 10%, 10, 12%, 10% of all births, and is the most common indication of second stage cesarean section nowadays. And there has been wide variation of obstetric management at full cervical dilatation, depending on the obstetrician on duty on the day or the night, depending on how experienced he is, how he have been exposed to such situation during his training or not. And that's why it varies greatly between different trusts here in the UK and across Europe, because I'm aware that some countries not even they have abandoned keel and forceps, keel and forceps, because basically I'm not quite sure if everybody's aware or not. Coalesce started in France like over 100 years ago by Norwegian guy, and then unfortunately the baby and the mother passed away the first time it was applied and used. The baby and the mother passed away, and that's why it was abandoned for a long time, and then until it started to come back. So basically, we did like some sort of survey here in the UK and like a while ago, and we found that only less than 10% deliver a woman as full cervical dilatation by cesarean section rather than instrumental vaginal delivery. And that another study found that many obstetricians either discontinue or never learn to use rotational forceps. So basically, we did some sort of retrospective observational study for 4 years in the UK from population-based register. We tried to see if any difference in the results and the outcome between the use of different rotational maneuvers, whether Coalesce forceps, whether rotation by manual rotation, whether it's by rotational vacuum extraction. So basically, we did 72 women who underwent the Coalesce rotational vaginal delivery, or includes the study, and we compared it to 69 other women who had rotational delivery, whether by vacuum or ventouse extraction or by manual rotation followed by direct forceps application. And the duty obstetrician who did this was none of the authors of the study or the project, because it was a retrospective observational study. So that it doesn't get biased. So this is the Coalesce forceps. As I said, I'm not quite sure if any of you have used it before or ever have seen it before. It will be found in museums as history in some trusts. And some trusts still use it. Some trusts don't allow it. Because I just give you a short, brief description how would you apply Coalesce forceps for doctors and who never seen it used before. Basically, we don't apply it the usual way we apply the forceps, the Neville-Barnes forceps or other forceps, because basically here the anterior blade need to come anterior to the side of the baby's head, needs to be to the front of the baby, not on the side of the pelvis, to the front, anterior of the baby. And then the blade then moved anteriorly in the cephalic presentation until it rests in front of the symphysis pubis. And then a posterior blade is inserted in the same manner. And when both blades are in position, we start rotation of the head before doing any traction. So basically, we start applying as a Neville-Barnes force, but then we have to rotate the anterior blade to be just behind the symphysis, in front of the symphysis pubis, or behind symphysis pubis, whatever you call it. And the posterior blade is applied the same way, so that they are front and back, not on the side of the pelvis. And then we rotate the forceps so that the baby get rotated in the occipital anterior position before delivery. The same applies to the ventouse, but ventouse, of course, is less traumatic and less risky, because suction cup here is applied the same as usually applied over the flexion point, about 3 centimeter anterior to the posterior fontanelle of the baby's head. And then here is different from Coalesce forceps, because with Coalesce forceps we usually rotate and then do traction. Here, no, we do rotation and traction at the same time, which is a big difference between the two instruments, because here rotation and traction, and the baby comes out occipital anterior position. But in Coalesce, no, we can't rotate and apply traction at the same time. We have to rotate first and then apply traction. And then rotation, basically, it is done with the hand of the operator obstetrician. Just apply gentle pressure to the anterior fontanelle to generate flexion, because we have to flex the baby's head first before, so that it makes it easy to rotate, or makes it feasible to rotate the head. And then is this impact from the pelvis, so that you can rotate to occipital anterior while your head is still inside the pelvis and remaining around the fetal head. This in brief, of course, the 3 procedure, but of course needs a sort of training, because instrumental vaginal delivery in general is a very risky procedure. is a very risky procedure if you are not proficient and if you are not well trained to do it. It can cause a lot of problem for the mother and for the baby and for the obstetrician as well, from medical legal aspect, of course. This is a brief description of my study here. It's not my, I've got other my colleagues as well. Basically, we included 141 patients in the study. 72 had Coalesce rotational forceps, 42 had rotational vacuum extraction, and 27 had manual rotation. And this talk about the indication. Basically, the indication was either failure to progress or pathological CTG. And then with the population, we classified into 5 models. First model were defined about to set easy to analyze the results. First model were the effect of Coalesce delivery and rotational ventouse and volume maternal complication were examined, comparing manual rotation. And then another model when we examined between the 3 methods in comparison to maternal age, BMI, and parity. And then we went to discuss any difference between fetal weight and how many weeks pregnant at the time of delivery. And then the delivery obstetric characteristic, what is the onset of labor and the number of pulls. And then the interaction of Coalesce delivery on the effect of multiparity and BMI, unlike involving maternal complication. That's to make the analysis more feasible of the results. And this is the results. I'll not go into it because it's too much. I've got more like graphs, which makes it easier. Because basically, as I said, it divides into 5 models, and it basically no much difference from the complication point of view and from the risk or complication point of view between the 3 methods. And then here it speaks about maternal complication and whether depending on the parity, whether Coalesce compare rotation into the main rotation. And as I said, maybe in the primary paras, the maternal complication is higher with Coalesce, but when it comes to multi-paras, it's more or less the same and overlap. The same if we talk about fetal weight, it's more or less no big difference. Maybe it's difference more observed when the baby weight is higher than 3.5 kilos. We have only one reported case of neonatal death by the Coalesce forceps. And when I look at the literature, I found that very few has been published, but we have to accept that this is one of the risks of Coalesce forceps. I'll just give you a brief summary of the case. Basically, she was a primary gravid woman. She had induction of labor at 39 weeks after prolonged spontaneous rupture of membrane for more than 24 hours. Labor progressed very well, and the baby was found to be in the right occipital posterior position in the 2nd stage of labor. The baby was born in poor condition, though his cord blood gases were 7.343 and 7.184, which clearly indicate that is some sort of acute distress happened to the baby. And the baby was diagnosed with hypoxic ischemic encephalopathy and was transferred and intubated to Great Ormond Street Hospital in London. One of the biggest children's hospital in London, basically, or even in Europe. It was trained for cooling, and he later died. It was difficult to say exactly the cause of the death because I said it's the operator who did the Coalesce forceps, as you have seen from study, he did over 70 cases, and none of them had any problem, whether the baby or the mother. But this happened, and he did conduct them well before and after this incident. It's difficult to tell whether it, because of rotation of the head in direct direction opposite to the fetal body, caused some shearing and injured cervical cord, whether the cause of death was injury inflicted by trauma as a result of excessive traction and rotation of the fetal head, and which led to carotid arteries injury, or whether some sort of undiagnosed fetal musculoskeletal anomaly. This study has some sort of limitation. Of course, the number is not big. I know we did 72 Coalesce forces, but I think to get to conclusive evidence, it has to be more number and across different, more nationwide. But of course, the value of this study is that I'm not quite sure how many there is positive publication in this subject of Coalesce force, as I said, because many countries abandon it, many trusts here in the UK do not allow the Coalesce forceps because, and this scale is vanishing, unfortunately. And the study as well did not report a long-term outcome of rotational operative delivery of maternal and fetal well-being. So what was the conclusion? Careful use of Coalesce forceps is not associated with any more risk to the woman and their babies than expected from any other method of rotational operative vaginal delivery. And there was no significant neonatal outcome apart from this, as I said, from this baby who passed away. There was no significant difference in neonatal outcome whether an indication was failure to progress of labor or non-reassuring fetal heart race. That basically, because we have to understand that the art of obstetrics not only about you are very good doing cesarean section or very good doing Coalesce or very good doing whatever instrument or whatever procedure you're doing. The most important thing is to have a knowledge and capacity of when to stop, when to abandon the procedure. When you said no, this procedure is not working. That is the main point we have all to focus on. Whatever experience we have, whatever good we are as there is, when to ask for help. This is the most important point for safe mother and babies. And nevertheless, we will have to admit that there will always be vaginal deliveries that progress to a stage where rotational operative delivery would be a safer option than complicated cesarean section, because most of us have done cesarean section and section delivery, and we all know how difficult it is and how it can become very complicated, and what are the risks of second stage cesarean section. It's important to have workshops for non-rotational and rotational operative vaginal delivery at early years of training, registrar level, not leave it until late stage. Of course, we have to train them on the non-rotational first, and then the rotational vaginal delivery at the registrar level, at the trainee level. And it should be done in a supervised simulation setting first, before we do it on live mother and woman. I know some trusts have got now simulation obstetric labs to do this in settings, and it marks them whether they do it right or wrong. Some trusts don't have it, but because evidence have showed that it's not the best thing to do the training on living mother and baby. There is an important need for training and structured discussion meetings for any case, especially with unexpected outcome, untoward outcome. Clinical audits are very important, and more important than a structured meeting between operators, as they are definitely be more productive. As I said, Coalesce forceps will remain still a safe tool for rotational operative delivery in a good hands, an experienced hand, in a well-trained hand, and as I said, with the operator who knows when to stop, when to ask for help. And we have to acknowledge and accept there is always a risk and complication with instrumental vaginal delivery, and with cesarean section as well, of course, with both. But this, we have to acknowledge such risk. We have to accept such risks. And very important for pregnant women to make them aware of such in an informed consent form of such problem with such procedure, and that because you will find that someone say I don't want instrumental, just go for cesarean section, and but we have to be informed consent from an operator who have done this procedure before, not by a house officer in the early days of training who are never seen, never done it before, so that she can give her informed consent to go ahead on such procedure. Thank you so much. Any questions?
Thank you, Dr. Mohammed, for your wonderful presentation. Does anyone have any query?
Yes, I do actually. Can you hear me, Mohammed?
Yeah, I can hear you.
Hi, Mohammed. I'm Albert from Auckland in New Zealand. I had a question. I think it's a very good, thanks for your presentation. I think it's a very good point that you made at the end that we need informed consent. Now that we know that with the forceps, we have around 80% of trauma to the pelvic floor muscles, which can lead in the long term to prolapse and incontinence. Is that something that you would put in your informed consent? Like the long-term effect?
Yeah, I can hear you. This is a very interesting question, actually. We have to admit that this pelvic floor trauma and damage does only is caused by instrumental vaginal delivery is a cause, definitely. I agree with you completely. But also the prolonged second stage and the prolonged straining and the prolonged push down can damage the pelvic floor muscle without using any instrument. Because pregnancy and vaginal delivery by itself, especially with prolonged second stage and prolonged bearing, can cause problems to pelvic floor muscles. Of course, instrument delivery is an added risk factor, but vaginal delivery by itself is a risk factor, and that's why if you speak to any urogyneo pelvic floor muscle consultant, he will say, I would not operate to any woman until she completes her family, because he knows that whatever he fixed with the pelvic floor muscle and trauma, it will be damaged again by pregnancy and delivery, even without instrumental. But I agree with you. Yeah, instrumental. It should have been. It should be written as a form consent that it causes damage to the pelvic floor muscle. But whether it's more damage than the prolonged straining, if she asks woman to keep pushing down for 1 hour, 2 hours, does the instrument cause more damage to it? It's difficult to answer this question.
Thank you very much.
Thank you.
Hello.
Dr. Hosni, I also have a question. This was actually a really great presentation. I'm not familiar with all the different types of assisted deliveries, right? And I think you said initially that the Keelan forceps delivery is different from other forceps delivery. Can you just briefly say how it's different and why it's more risky? I missed that part earlier.
Yeah, thank you very much for your question. Basically, Keelan forceps, when it was designed for rotation of the head, because basically the most common position of the baby is usually occipital anterior position, whether right occipital anterior and the left occipital anterior, and it is the most easiest way to have a vaginal delivery, especially with the mechanics of the delivery. But if the baby comes down as a position in second stage as occipital posterior, whether right occipital posterior, left occipital posterior, transverse occipital posterior, you cannot do like the usual force, which is Neville Barn forceps, whatever force you use to deliver the baby in this position, because baby will not come. The mechanics of the pelvis will not allow the baby to come down. So we have to rotate the baby to a different to occipital anterior position before we can deliver the baby, because it's not possible to deliver the baby in right or left occipital posterior or transverse occipital posterior. It's not possible. The mechanics of the pelvis does not allow it. So we have to change it to a more favorable position so that the baby can be delivered easily. And to change it from occipital posterior transverse to occipital anterior, we can't use Neville Barn forceps, because Neville Barn forceps has got a pelvic curve, has got a cephalic curve. It's different from the Keelan forceps, because let me go show you back the Keelan forceps. It could be different from Neville Barn. It hasn't got the cephalic and the pelvic curve, because you have to apply it. You apply it basically in the same way, but you have to rotate the anterior blade to be behind the symphysis pubis or in front symphysis pubis. As a posterior blade, you put it initially in the pelvis on the left side, and then you put it back. So the forceps blade will be top and bottom, not right and left. After you apply the blade top and bottom, you have to rotate the baby's head. Rotate the baby's head before applying any traction.
Okay.
That's the main difference between this one and other one, because other one with Neville forceps or Neville Barn forceps, you apply it directly with the pelvic curve and the baby's head, and you pull traction. It will be on the sides. The first application will be on the sides of the pelvis, on the sides of the baby's head. But with Keelan forceps, the first application will be Yeah, we'll put on sides, but you have to make it on the top and the bottom of the baby's head so that you can rotate it before you pull down.
Okay.
Does this answer
Thank
your
you.
question, or?
Yes, sir. Yes, sir. Thank you.
Yeah. Any other questions?
Yes, Dr. Mohammed. Salam alaikum. My name is Dr. Susanna. I'm professor of obstetrics and gynecology in Alexandria University. Actually, I just want to thank you for this interesting presentation that makes us think of this instrumental deliveries. That's very important issues. And I want to ask you about these complications you have mentioned in your presentation about the crushing of the spinal cord or spinal vertebra and the crushing of the carotids. Did you encounter such cases, and what happened next? That's my question. I'm curious to know.
What do you mean? What happened next?
The baby that had this crushing of the
The baby
vertebrae,
was
or
transferred to Great Ormond Street, and he was intubated, and unfortunately passed away in a few days.
okay,
And
and
we looked in the literature, we found that this happened in different trusts. But the operator is a very experienced and skilled operator who managed to perform successful Keelan before this incident and after this incident.
okay, but in your study, you didn't acquire such very big complications.
No, we had of course other complications. Like you mean like perineal tears, like maternal complication or fetal complication?
No, the issues, the fetal complications, this spinal cord injuries and
No,
vascular injuries.
no, the rest were all babies were delivered well and went home with the mother same day or next day.
Okay, great.
They were all delivered well.
Okay, I want to ask you about your personal experience. You, in these cases of occipital transverse, for example, you will try first to manually rotate the head, and then if it fails, you will try the Killen forceps.
No, this, yeah, I know what you mean. No, you don't do it like manual doesn't work. You move to rotation of ventouse, does work. You move to Keelan. No, it depends on situation. To be honest, Professor Susan, it depends. Hopefully, I recall your name right. It depends on
Yes.
situation, on the experience as well. It's the same like when you see a woman and she needs assisted delivery. Do you choose force or you choose ventouse? It depends. It comes with experience and training. You can't say we try this and does work and move to another, let move to another. No, there is like it comes with the training and with the criteria and a lot of other things. But I don't try it one after the other, and that's why I
Yes.
said
No. No.
we have
I
to know
didn't.
when to stop.
Yes, I didn't mean that you try ventouse first and then Killen. No, I mean the manual rotation first, and if it fails, you do the forceps.
Yes, you can, of course. You can, of course.
Okay,
Of course.
so another question, if you let me. Did you feel like there is true difference between the Killian forceps and the usual, the long curved forceps in this issues? Because actually I have the experience to do this, not maximum rotation, but minimal rotation with the long curved forceps before the extraction of the baby.
Yeah, I mean you're using Neville barn force to do minimal rotation of the baby, correct?
Yes, the long curved forceps, the traditional one.
Yeah, the Neville barn ones, yes. You can do it, but it might cause more pelvic floor damage. It might cause more
So
perineal
you
tears.
recommend that the Killen forceps causes less maternal complications than the long curved forceps?
I didn't say that. But to use the other forceps for rotation when it's not designed to can cause more problems than you use Killen forceps for rotation which is designed to. That's what I meant.
Okay, thank you, Dr. Mohammed. Thank you.
Thank you. Any other questions?
Thank you.
Great job.
Hope there are no more questions. Thank you once again, Dr. Mohammed Hosni, for your wonderful presentation, and that was a great discussion. Let's move on to the next presentation.
Thank you.
The next presentation is by Dr. Susanna Eze from King Saud bin Abdulaziz University for Health Sciences, Saudi Arabia. Hello, Dr. Susanna. Are you ready with your presentation?
Hello, yes, I am.
Okay, so I'm making you as a presenter right away. Yes, I made you the presenter. Please click on the share button to share your screen. Hello, Dr. Susanna. Kindly click on the share button to share your screen.
Oh, yeah, it's gray. It's not allowing me to press it.
Are you a MacBook user?
Yes.
Okay, then you have to go to this. You go to your system preferences, and then you have to
Mm-hmm.
give permission in your system preferences, and then you have to leave the session and rejoin the session.
Oh, okay.
First, you share the screen, go to the system preferences, and
Mm-hmm.
give permission there.
Mm-hmm.
To the GoToMeetings app, you have to give permission to the GoToMeetings app, and then come again and leave the session and rejoin the session.
Okay, so I did. I'm going to be leaving it right now and I'll be returning.
Hello, Dr. Susano. Can you hear me?
Yes, I can. Can you see the screen now?
No, not yet. Yeah. Yeah. Your screen is visible. Please
Okay.
open your PPT.
Mm-hmm. Okay.
Yeah, that's
Is
perfect.
everything okay?
Please continue. Yeah, that's perfect. Continue with the presentation.
Okay, thank you so much. So good morning, everyone, or good afternoon. Sorry for the delay. My name is Susanna Eze, and I'm a senior medical student from King Saud bin Abdulaziz University for Health Sciences in Saudi Arabia. So I'm going to be presenting my research today titled Midazolam versus Lorazepam, a comprehensive evaluation of the effectiveness and safety in pediatric status epilepticus. So I'll be first going over a brief introduction and then our objectives, our methodology, results, discussion, and finally the conclusion. So first, as a brief background, what is status epilepticus? It's basically a medical emergency characterized by either a prolonged or recurrent seizures that typically last for 5 or more minutes. It's actually one of the most common presentations in the emergency department, especially amongst pediatrics. And unfortunately, it is associated with significant morbidity and mortality. It can lead to serious and irreversible neurological damage or even death if not promptly and effectively managed. That's why it's very important that we find the fastest and the most effective ways to control seizures. Now, the current standard in many different guidelines and protocols worldwide is to use IV lorazepam. It is the most commonly used first-line therapy for acute seizure control. However, there do exist cases where obtaining IV access would be an obstacle, especially in a child who's actively seizing. Other first-line medications, including IM, intramuscular lorazepam, or IV diazepam, valproic acid, rectal diazepam. However, all of these are common in having several obstacles in the routes of administration, such that they either require a trained healthcare professional to administer, or they require appropriate resources or equipment, such as the needles, or they might require refrigeration, or a certain setting to be administered, such as the rectal diazepam. It would require a private setting to be administered. This is the algorithm to treating convulsive status epilepticus as published by the American Epilepsy Society as of 2016. And as you can see, it highlights the first-line medications I have mentioned earlier. However, there does exist another benzodiazepine, midazolam, which is actually one of the few that offers the intravenous, the intramuscular, as well as the intranasal route. There has been previous trials that have concluded that the intranasal route is actually comparable in its efficacy and safety to lorazepam, with actually a faster time to administer than IV or IM lorazepam. However, these trials are limited and there is a major gap of evidence. There was no systematic review, as of our knowledge, before this one that had actually pooled the evidence from all of these different trials and systematically compared and assessed the efficacy and safety of midazolam compared to lorazepam in treating status epilepticus amongst children. Therefore, our objective from this study was a systematic review and a meta-analysis to assess and compare the efficacy and safety of intravenous lorazepam, the most commonly used first-line therapy, versus intranasal midazolam in managing status epilepticus in pediatric population. Now, briefly about our methodology. So we have systematically searched 4 different databases, including Medline, Cochrane Central, Science Direct, and Web of Science, from their date of initiation up to the 4th of July of the current year, with the keywords benzodiazepines, midazolam, lorazepam, status epilepticus, seizure, or children. We have included any RCT that had compared midazolam versus lorazepam in pediatric patients, which we have considered to be 18 years or younger. We have excluded any study that did not meet the inclusion criteria or was non-English. We have assessed the risk of bias for all of the included papers using the ROB2 criteria, where we had 2 authors independently and in duplicate assess the included papers for their risk of bias. The statistical analysis was run through Revman using a random effects model to consider for potential data heterogeneity for all the different outcomes. For our significance, we have considered a p-value of 0.05 or less to be significant. Our dichotomous outcomes were represented using risk ratios, and continuous outcomes were represented using mean differences or standard standard deviations. Of course, all steps of this systematic review were following the PRISMA guidelines. So this flowchart summarizes our screening process. So as I mentioned earlier, we have used 4 different databases and we were yielded with 3,009 articles, as you can see from the first box on the flowchart. And then we have removed the duplicates. We have screened by title and abstract, and then screened full text for 10 of the articles. And then finally, we were left with 4 articles that were ultimately included in our meta-analysis. So the 4th objective is to discuss the results. So as I mentioned, we had 4 RCTs included with a total of 326 patients with 163 for each arm. Their baseline characteristics, including the ranges of age, the doses, and the etiology of the seizure, are summarized in Table 1, and they are relatively similar, as you can see. No, for our outcomes, we had several outcomes, but to make it easier, they could be categorized into two main categories, the rate outcomes and the time outcomes. So I will first start by discussing the rate outcomes. We have first the rate of success of the medication in terminating the seizure. And there was actually no significant difference in terms of the rate of success of the medication. We have run a subgroup meta-analysis based on the route of administration. So as you can see on figure 2, this forest plot is comparing first IV lorazepam with first the intranasal midazolam, and then intramuscular midazolam, and then intravenous midazolam. As you can see on the lowest diamond of the screen, the pooled evidence of all of them was actually that there was no significant difference between the two, as the diamond is crossing the line in the middle. Other rate outcomes have also displayed no significant difference, including the rate of the medication failure in terminating the seizure, the rate of seizure recurrence, the rate of the need of another rescue medication, rate of endotracheal intubation, and the rate of respiratory depression. For the last one, however, we were not able to actually run the analysis because it was a solid 0 for all arms across all the different studies. So we were not able to run the analysis for this one. But for the others, as you can see on the forest plot, this for figure 3, it's actually the forest plot for seizure recurrence. We have also run a subgroup analysis based on the route of administration, and there was also no significant difference for all of them. So this is actually the important definitions I thought it was important to mention. Different studies had different definitions in terms of what they had called to be seizure the medication success, the medication failure, or in seizure recurrence. There were slight differences across the studies, which might have resulted in some variation. It could be considered a limitation. Next, I move on to the time outcomes. So we had 3 main time intervals included in the RCTs we had included. So this diagram I thought would make it easier. So we first had, starting from number 1, from the left side of the screen, there's first the time of patient's arrival to hospital, and then time of drug administration. And then number 2 is from the time of drug administration to time of seizure control. And then number 3 was all the way from the patient's arrival to the hospital all the way to the time of seizure control. Starting with the second one, which was from drug administration to seizure cessation, our meta-analysis has revealed no significant difference between the two arms, as displayed on figure 3. However, intranasal midazolam was actually superior to intravenous midazolam, meaning it required a shorter time to administer than intravenous lorazepam, as displayed on table 3. So as you can see in one of the studies, the time was almost half the time required for intranasal midazolam compared to the intravenous lorazepam, which was almost double. This is in turn reflected in a shorter time from the patient's arrival to the hospital to the time of the seizure cessation. So for the discussion, to summarize, we had pooled data from 4 different trials, including 326 children, and we have concluded that there has been comparable safety and efficacy between midazolam and lorazepam. However, intranasal midazolam requires a shorter time to administer, which is extremely important in a condition like acute seizure or status epilepticus, where each minute matters. It could prevent serious irreversible damage. This could likely be justified by the feasibility and the convenience of the intranasal route in terms of its administration. Also, the unique properties of midazolam as an anti-seizure medication. The highly vascular nasal mucosa could be actually the reason that it offers a quicker absorption as well as direct penetration to the central nervous system from this route compared to other routes, including the IV or the IM. However, there are limitations that are important to mention in this study. The first being there might have been potential small study bias because we only had 4 RCTs included with a relatively small number of patients. Number 2, publication bias was actually also not able to be assessed, also due to the small number of included articles. Number 3, there might have been potential geographic bias, as 3 of the 4 RCTs we had included were actually conducted in India. So this could have created an evidence gap for other regions of the world. Number 4, we had some missing or poorly reported data and some of the time outcomes that have made it not possible for us to run the analysis, which could have resulted in a stronger or more comprehensive conclusion. Number five, as I have mentioned earlier, so different studies had different definitions in what they had called medication success, medication failure, or the recurrence of the seizure, which might have resulted in some variability in the results reported. Therefore, we do recommend that future research is encouraged to provide further evidence to assess and compare lorazepam with midazolam. However, clinically, we do recommend intranasal midazolam is considered as a promising alternative to IV lorazepam in both the pre-hospital and the hospital setting, especially in cases where IV access is difficult. So in conclusion, this meta-analysis has concluded that midazolam is an equally effective, safe, feasible, but with a faster time to administer than IV lorazepam in cases of difficult IV access, as I've mentioned. These are my references if you would like to scan the QR code. Thank you so much for listening. I'm available if you might have any questions.
Dr. Ezzy, that was a really great presentation. Um, uh, your first forest plot was interesting in that a lot of the favorability for lorazepam, although you said there was no significant difference, but a lot of that favorability for lorazepam was being driven by study number 3. I wonder if study number 3 was so different from the other 3 studies so as to not be appropriate to include.
You
Yeah,
mean this
this
one?
one's study number 3, right? That the 1.4.3.
Yes, I do understand your question. Thank you so
Okay.
much. That is an interesting one. So I think you're referring to the heterogeneity of this study. We had a very low heterogeneity for most of the outcomes. It was the I squared was 0%. So I don't think this might have impacted the overall result. Yes, I agree with you. It does favor midazolam. It is the final diamond is going more towards the left, favoring midazolam. However, it crosses the line, so I think there's no significant difference between the two arms.
Okay.
Does anyone have any queries? Hope there are no queries. Thank you very much, Dr. Susanna Ezzy, for your wonderful presentation. And let's move on to the next presentations. The next presentation is by Dr. Grace Mander from Herbert Kairuki Memorial University, Tanzania. Hello, Dr. Grace. Are you ready with your presentation?
Hello.
Yeah, I'm making you the presenter. Please click on the share button to share your screen.
Okay. Good afternoon.
Good afternoon.
Okay, thank you very much for this opportunity to present our paper result in this European
Hello, hello,
congregation.
Dr. Grace. Sorry for the interruption.
Yes.
Kindly make it a full screen. Your screen is visible, but make it a full screen.
It is full
Kindly
screen.
click
Yes.
on the click on the slide option below at the bottom right corner,
Yeah.
or else click on the presentation mode. Yeah,
Yes,
that
I'm
one. Yeah,
trying.
yeah, that's perfect. Yeah, it's perfect now. Please
So
go
good
ahead.
afternoon again. Hello.
Yes, you're
Good
audible. Good
afternoon. It's
afternoon.
looking. Yeah.
Kindly go
Okay.
ahead with your presentation.
Yeah, okay. Thank you very much for this opportunity to present our result paper. My name is Dr. Grace from Department of Pediatric and Child Health, Herbert Kairuk, and with the title of Magnitude and Cause of Early Neonatal Mortality at Public Regional Hospital here in our country, Dar es Salaam, Tanzania. And uh, uh, it has been shown that the neonatal mortality is still a challenge in many countries, including Tanzania, with the fact that urban areas reporting to have higher mortality rate compared to rural areas. And to understand this problem, we thought we have to set the mitigation strategies. There is to need to do a research on the actual magnitude and the cause of this death. So also, it has been shown that Tanzania has been a major contributor on the global burden in early neonatal mortality, of which it has been estimated that about 40% of under 5 deaths occurring within the neonatal period, of which 65.5% death occur within 24 hours post delivery. So also it has been shown that uh, globally about 6,500 newborn are estimated to die daily, and this has been reported by UNICEF by 2022. And about nearly three-quarter of newborn deaths occur within the first week of life, of which about one-third of it occur within 24 hours. And this has been reported by UN Interagency for Child Mortality 2020. And I mean, South Asia and Sub-Saharan African contribute about 79% of this death, and this all of these deaths are occurred in low and middle income countries. And East Africa and West Africa has been leading on death, of which Nigeria, Ethiopia, and Tanzania have been shown to have higher early neonatal death, of which quarter of it occur within 24 hours post delivery. So the primary objective was to determine the magnitude and cause of early neonatal mortality and at this public regional hospital in this Dar es Salaam city. And the secondary was to determine the factor associated with this early neonatal mortality. And this study was done in 3 hospitals, Amana, Temeke, and Mwananyamala here at Dar es Salaam. And it was a hospital-based retrospective observational study, and the study population was all neonates who had born with less than 7 days of life or equal, and who were admitted in the neonatal unit with different condition. And the data collection tool was pre-designed case report form. And on method, we analyzed our data by using the EPINFO version 7.4, and the continuous variables done with median and interquartile range, and the categorical variables were analyzed by frequency and proportional, and the factors that were associated with early mortality were analyzed by binary logistic regression analysis. So on the result, about total of 370 neonates were analyzed, and about 104 died within 7 days of life, and this make a magnitude of about 28.1%. The prevalence was 28.1%, and on the 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 basic characteristic of the neonate. For the continuous variables, the median age was 6 days of life, and the median weight was 2.7 kilogram, and the median respiratory rate was 60 breaths per minute, And for the categorical variables, as I said initially, for Amana, we repeated 157, neonate, Mwananyamala 87, and 126 from Temeke. And from this group, about 54.1% were male and 45.9 were female. And most of this group, about 263 were delivered at by spontaneous fetus delivery, which carried about 71.1%. And those who were born in the hospital was 206, which carried 55.1%. And at day 7, the status was those who were alive at day 7 were 251, which carried 67.8%. And those who died were 104, which carried 28.1%. And those who were referred to higher centers were 15, which carry 4.1%, and almost these neonates were referred at 7 days of life. So for the maternal characteristic, most of these mothers, they had age of 28, 27 years old, and for the number of antenatal visits, was most of them were poor. The highest, the median was 4 visit, and these mothers group, about 284 they were, which carry 76.8% were married mothers with education of uh, secondary education level, which were they were 188, which carry 50.8%. So we did analysis on the chi-square to see the condition on admission that was directly associated with early neonatal death. And as you see there, the birth asphyxia, about 43 died, which was statistically significant risk factor for causing early neonatal death with p-value of 0.00. And you had premature as well, with 36% died, which was highly statistically significant, being a premature with a p-value of 0.2. And also the respiratory distress, about 65.1 of these babies died within 7 days of life, and this was statistically significant risk factor with p-value of 0.00. So for analyzing factors, we did the regression, binary regression model, as I said earlier. So we did them for the mothers. We found only one antenatal visit, as you see here on the crude and adjusted odd ratio. It was shown that for those mothers who had poorly antenatal visit, they had high chance of losing their baby within 7 days of life, with a p-value of 0.03. But when we shifted to adjusted crude ratio, it was not significant. So for the neonatal factors, several factors was found to be statistically significant on crude ratio, as we analyzed respiratory rate, gestation age, birth weight, temperatures, and UPGAR score. And when we shifted to multivariate, only respiratory rate was shown to be statistically significant, increasing risk of death within 7 days of life, of which it has been shown like to every child, to every increasing 2.9, to every child increasing of 2.7%, this study increasing elevation of respiratory rate, this neonate has a high risk of dying within 7 days of life. For the birth weight, for the gestational age, also was statistically significant for both univariate and multivariate, but this association factor was protective for those who survived. As you see here, it has been shown that for those neonate mothers who gestation age were increasing at least for 1 week, these babies were having high chance of surviving. So this is a pie chart that's showing the frequency of underlying cause of neonatal death in these hospitals in our country, Dar es Salaam. So as I said earlier, the birth asphyxia, prematurity, respiratory distress were the leading factor, as well as neonatal sepsis. So as I said area on a factor that was on multivariate binary logistic regression analysis, which was independently factor found to be associated with early mortality were only elevated of respiratory rate. So on discussion on early neonatal death, we saw that the neonatal death in our country is still high, and this finding was related and similar to other study that was done with Wedi et al. In 2019. He found also about 34.7 neonate died within first week of life, as well as Ahmed et al., which was a prospective study done in Ethiopia. Also, we found that in 2019, about 1/3 of those neonates died within 7 days of life, as well as Moshiro. This study was done in our country, and also Mango et al. In 2021, they both found the same thing. So on predictors of early neonatal mortality, so the neonatal respiratory rate on admission was shown to be the factor, and this has been similar to other study like Mango et al. On 2021. He found about respiratory distress, respiratory increase in respiratory rate was contributed to 21% increasing risk factor of losing this baby within 7 days of life, as well as the study done with Reyes in our country at Arusha here, Tanzania. Also, we found increasing respiratory rate was a highly risk factor of causing death in this neonatal group. So, also the maternal factor, as we found, only the poorly antenatal visit has a high chance of increasing death to this neonat. This study was the same as the study done with Grebe Marian et al. In 2021 Ethiopia on the prognostic risk score. We found the same, that those mothers who didn't attend antenatal clinic at least more than 4 or 5 to 8, they had a high chance of losing these babies at the 7 days of life. So also on clinical diagnosis, we found that other potential factors, as I said earlier there, that the birth asphyxia, respiratory distress, and premature were statistically significant on associating with early neonatal death. And this was similar to other study that has been done in different countries, like Shire et al., that was done in 2019, as well as Fisher et al. In Ethiopia, which was done in 2022. So in this study, we recommend that early neonatal mortality rate, as we saw, it is very high, and birth asphyxia and respiratory distress syndrome and complication of prematurity has been leading to this and increasing this early neonatal death. So we need to intervene on infection prevention and control effort appropriate to management of labor and interpartum complications, so that we can minimize these deaths. So thank you.
Thank you, Dr. Grace, for your wonderful presentation. Does anyone have any query? Hope there are no queries. Let's move to the further presentation. Once again, thank you, Dr. Grace, for your wonderful presentation.
Thank you.
So the next presentation is by Dr. Liknau Bekwet Zaliki from University of New South Wales, Ethiopia. Hello, Dr. Liknau. Are you ready with your presentation?
Yes, I'm here.
Okay, I'm making you the presenter. Please click on the share button to share your screen.
Okay.
Yes, yes. Karibu, nimefungua ambayo sio. I don't know. You have, there's one bottle of beer here. Yes.
Hello, Dr. Grace. Can you please unmute yourself? Hello, Dr. Grace. Yeah, thank you.
Yes.
Yeah, please unmute yourself. Thank you. Yeah. Yes, Dr. Licknow Beckwith, your screen is visible. Please make it a full screen.
Uh,
Yes, your screen is visible. Please make it a full screen.
yeah, what about now?
No, not yet. Please make it a
Uh,
full screen. Please click on the slideshow option at the bottom, the fourth
okay.
icon. Yeah, that one. Yeah,
Yeah, is
it's
that okay?
perfect. Yes, it's okay. It's perfect. Please continue with your
Okay.
presentation.
Okay, thank you. I'm Likenau Bogat from Ethiopia. Currently, I'm a PhD student at University of New South Wales in Australia. So my presentation title will be on treatment outcomes of obstetric fistula, surgical repair in low and middle income countries. It's a scoping review study. So my presentation outline looks like this. It contains the introduction, methods, results, discussion, and limitation and conclusion of the study. So to start with the introduction, in literally speaking, fistula is an abnormal communication between two hollow organs. So it can happen in the esophagus, intestine, and in the reproductive tracts. It may occur likewise. So in the case of obstetric fistula, it is a form of fistula which occurs between the urinary tract and or anorectal tract with the genital tract. So the abnormal communication may occur with between the genital tract and either the urinary tracts or the anorectal tract, and mainly it is caused by ischemia and necrosis due to prolonged obstructed labor. So, generally speaking, to state about the prevalence and incidence of obstetric fistula, there is no accurate and reliable data globally, but it is estimated that nearly 2 million women are living with obstetric fistula problem worldwide, and it's also estimated that around 50,000 to 100,000 cases occur every year. Overall, obstetric fistula is not as such a big problem for developed countries, but it remains a major public health challenge in resource-limited countries. And when we see the burden of obstetric fistula for every victim or every woman, it may impact the physical health, the social health, the mental health, and economic status of the woman. When we talk about the treatment outcomes of obstetric fistula, basically the treatment may take conservative treatment or surgical interventions. So it depends on the specific conditions of the patient, and mainly the treatment outcome of obstetric fistula may depend on factors such as presence of chronic illness, place of residence, duration of labor, fistula type, and the size of the fistula, the degree of urethral involvement or damage, appearance of scar, treatment center facilities, and the size of the bladder. In the preliminary search, before conducting this scoping review, the authors confirmed that there is deficiencies in the published review literature regarding obstetric fistula treatment outcomes. Therefore, this scoping review aimed to present possible treatment outcomes of obstetric fistula following surgical repair. So when we see the methods that we have used, we started by registering the topic of the study at Open Science Framework registers, and we developed protocol based on the JBI guideline, and we outlined the protocol based on PRISMA scoping review outline. To make eligible the studies, we set this criteria. Basically, studies should be conducted among women who received obstetric fistula surgical repair at health facilities. Studies should be conducted in low and middle income countries, and we didn't limit our studies based on publication year, and our study was also limited to studies published in English language, and there should be also full studies. In terms of source of information, we considered primary research, systematic reviews, meta-analysis, and other relevant studies, including qualitative studies and even scoping reviews. The search strategy included searches on databases, mainly on PubMed, Embase, Sinhal, Scopus, and Web of the Science database. And we also considered gray literatures, basically Google Scholar, Google, and some conference proceedings. We constructed a logic grid based on the population concept and context framework, which is recommended in searching for studies mainly on cross-sectional studies, and we limit our study on low and middle income countries, and we considered the Cochrane limit filter to access studies from the low and middle income countries. And finally, we expanded our searching by using forward and backward citation search strategy. The studies were selected using EndNote, and we presented with Prisma flowchart, and two authors independently conducted the search and the study selection, and a third author was invited to manage disagreements between the two authors, and the data charting was conducted by constructing a data charting form, which was outlined based on the JBS scoping review data charting criteria. And finally, we analyze the data using descriptive statistics, and finally we presented our findings using tables and some figures. So the data, when we come to the result section, the search is a result initially displayed resulted in around 2,718 studies from databases, and 13 studies from other sources, and finally we used 57 studies in our study. In our scoping review, we included 57 studies. So when we see the characteristics of the studies based on their study design, majority of the studies were cross-sectional studies followed by retrospective cohort studies, and we included qualitative studies, mixed method studies, prospective studies, case control studies, scoping review studies, mini review, and case series and randomized controlled trial studies in our scoping review. But in terms of country-wise, majority of the studies were from Ethiopia. Around 15 studies were from Ethiopia, and one study were obtained from nearly around 11 studies. 11 countries contributed one study. So finally, we presented the main finding of this study by categorizing treatment outcomes of obstetric fistula into two: early outcomes and late outcomes. The early outcomes included successful repair, incontinence, surgical site infection, urine retention, and hemorrhage and retained catheter, whereas the late outcomes included fistula recurrence, residual incontinence, quality of life change, fertility and reproductive related outcomes, mental health related outcomes, and family and social support related outcomes, financial instability related outcomes. So we categorize the treatment outcomes of obstetric fistula into early and late based on their timing of occurrence. So the early treatment outcome refers to outcomes that occur or that can be experienced before the discharge, whereas the late outcomes are the outcomes that experienced after discharge, and the patients may complain or come back in the regular visits or follow-up visits, or they may also come with complaint. And so the main criteria for the categorization was timing of occurrence. So when we come to the discussions, this review identified the treatment outcomes of obstetric fistula, and it classified into early and late outcomes. And as I stated, the early outcomes refers to outcomes that are observed before discharge, whereas late outcomes for after discharge. Overall, our review revealed that multiple studies have been published on successful fistula closure and incontinence on the short treatment among the short term outcomes or early outcomes. The review also noticed that researchers did not emphasize on post-repair outcomes such as infection, bleeding, and urine retention, which may need emphasis like other patients' surgical treatment services. They may also they should also give attention on these outcomes. And the researchers evaluated patients on follow-up visits to assess long-term outcomes, and on our observation, it ranged from 1 month to 15 years after discharge. The majority of the reviewed studies aimed to assess quality of life improvements or sexual and reproductive life and mental health outcomes from long-term or late outcomes. The review also shows that further studies are needed regarding family and social support and financial stability related outcomes, which are critically important in integrating patients following surgical repair or after the treatment of the fistula. This aspects of the patient's life has to be also studied and explored further. Most studies do not use advanced study designs as I had displaced on the pie chart. Majority of the studies were cross-sectional studies, so most of the studies did not use advanced study designs. Many of the studies focused on short-term or early outcomes and mainly on closure and continence of fistulas. As a limitation, this study was limited to full text studies and studies published in English language. So this study excluded potentially relevant studies published in languages other than English language, and studies available in conference abstracts. As a conclusion, this scoping review identified 57 relevant studies and presented the treatment outcomes of obstetric fistula by categorizing into early and late outcomes. And this review finding indicated that most of the included study focused on successful closure rate and incontinence-related outcomes, and limited number of articles are available on other categories, mainly late outcomes. And the findings of this review can also be used as baseline for researchers to conduct primary studies with advanced designs to generate robust evidence and identify all the possible outcomes of obstetric fistula. Therefore, we, the authors, would like to recommend conducting primary longitudinal studies with long study period to encompass all the possible early and late outcomes of obstetric fistula. So thank you. That's my presentation looks like. Thank you.
Thank you, Dr. Likhna Beckwith. That's a wonderful presentation. Does anyone have any query? I think Dr. Atya asked a few questions. Uh, Hello, Dr. Atya.
Yeah,
Can
her,
you
her
hear me?
questions are in the chat.
Yeah, yeah. The questions are in the chat. Hello, Dr. Likhna.
Yes.
Yeah, there are a few questions in the chat box.
Okay. Can you read them for me?
Yeah, yeah, I'll read it. I'll read them for you. The first question is diabetic women are more prone to such fistula?
Uh, In terms of this study, yeah, basically, based on this study finding, I didn't emphasize on the determinants of fistula, but in separate another study, I tried to review literatures, and basically the presence of comorbidities such as uh, diabetic mellitus and other problems increases the likelihood of obstetric fistula. Mainly diabetic women may have a large fetus, and while giving birth, large fetus, especially in the resource limited settings, it becomes unlikely to give successfully through the vagina for large babies. So during these situations, the women may stay on labor for prolonged period. So this prolonged obstructed labor, one of the cause of obstructed labor is large fetus. So due to that, they are at risk of developing obstetric fistula. But based on this study, it's not the scope of this study. But from my experience, yes, women who are diabetic are more prone for obstetric fistula.
Okay. The second question is why other options for treatment other than surgery, like laser therapy? What other options for treatment other than surgery, like laser therapy?
Likewise, the previous question, this question is not also under the scope of this study, but I'm not a clinician, and I'm not fully engaged on the treatment of obstetric fistula by now. So what I'm studying is the effectiveness of studies the treatment options like uh, the surgical repair and conservative treatment on obstetric fistula. So I cannot tell in detail about this because I'm not a clinician by now. So yeah, it's not the scope of this study.
Okay, thank you. Thank you, Dr. Ligno, for your wonderful presentation. I hope there are no more queries. And as per the schedule, let us take a lunch break. We'll be back after 30 minutes from now. Everyone, please stay connected.
Thank you.
Thank you.
This conference will now be recorded.
Hello, everyone. I hope everyone is back for the afternoon session. Let us move into the session. So the first presentation is an oral presentation by Dr. Lakshmi Jairaj from Wrexham Malheur Hospital, United Kingdom. Hello, Dr. Lakshmi Jairaj. Are you ready with your presentation?
Hi, hello. Yes, I'm ready.
Okay, so I'm making you the presenter. Please click on the share button to share your screen.
Okay.
Yes, please click on the share button to share your screen. Yes, your screen is visible. Please make it a full screen and start your presentation.
Is it okay now?
Yeah, it's perfect.
Okay. So hi everyone. My name is Lakshmi Jairaj. So I'm a registrar in Obstetrics and Gynecology in Wrexham Hospital. So we are in North Wales, United Kingdom. We are part of Belstay University Health Board. I thank my supervising consultant, Ms. DeCosta, for this project. So this is a quality improvement project. This was done in our department. This is about women's involvement in induction of labor. So we have analyzed whether they are taking an informed decision of their choice. So a little bit on the background. We all know that induction of labor is very popular nowadays because it's been increasingly used for maternal reasons as well as for fetal reasons. So we know that it has a huge impact on the birth experience of the mother because it's an artificial process, it is more painful, and it is also associated with complications. Because it's more painful than spontaneous vaginal birth, mothers should be given different options of pain relief, and they should be given time to think about the procedure and to think about whether they need to have that or not. They should be provided with alternative choices, and they should be aware that what are the options available if it fails. So our audit standard was a NICE guideline. So the NICE guideline on induction of labor, so that is guideline CG70. So it provides recommendations on provision of information of induction of labor and the importance of shared decision making with the family. So it says that we have to discuss preferences about the mode of birth, and we should do it very early in the gestation. We have to discuss what are the methods of induction of labor available in the unit. We have to discuss how we are doing it, when we are doing it, and why are we doing it in a specific gestation age, depending upon which gestation age is the mother. We also have to provide what are the alternative choices for induction and what are the consequences of those choices and what are the risks and benefits of those choices. We have to provide different pain relief options, basically, whichever is available in the obstetric unit. And we should give some time to reflect on their decision, and we should give some time to have a discussion with your family as well to decide on whether to have an induction or not. So a sample size was 25 women. It was a retrospective analysis. So for the audit, the data was analyzed from the maternity electronic records, and it was analyzed and a report was populated. So along with the audit, we also did a survey because we need to know in the audit part, we are pulling the information from the electronic records. So obviously we can only see whatever is documented. So we needed to know whether we are actually discussing this and we're not documented, or whether we are not discussing this at all. So we have done a survey as well, along with the audit as a different arm. So the survey involved distribution of a questionnaire, which was prepared by us, and then we distributed it to mothers in the postnatal ward who had induction neonatal period. So the mothers will fill that in, and it is collected back with the midwives, and it was analyzed by us for the outcome. This was a completely anonymous one, so no patient identifiers was used in the survey. So we had 4 measurable standards for the audit. So the first one was there should be a documented evidence of discussion about the process and the need of the induction of labor, and also about the membrane sweep. So the second one was about options and opportunities of shared decision making with the family. Third option was about different analgesic options should be discussed with the mother about induction. And fourth one was women should be asked about their preferences on what format of induction of labor information that they would prefer. The standards for the audit was definitely set at 100%. So we have different questions under each standard. So on the first one, we have asked different questions, whether they knew about the process and whether they knew about membrane sweep, what are the information about membrane sweep that they knew about, and whether they were informed about the usual consequence of a membrane sweep, to know which is a red flag sign, which is not a red flag sign. So these were the questions that we used for standard 1. So the audit results have showed us that we are very poor in the audit standards, because obviously, as you can see, we have percentages ranging from 8% to 77% there, and none of them has reached 100%. On the survey, we did get some better results. Many women, 100% of women knew what they were going to have, like when, where, and how induction of labor is to be carried out. And majority of women knew the risk and benefits of induction of labor. So that was good from the survey part. About standard 2, whether options or opportunities of shared decision making was made with the partner and the family. So our audit results were definitely poor. So whether adequate time was given and whether questions were encouraged, whether options other than induction were discussed, and whether adequate support was provided to the mother for decision making. So as I suggested, we have pulled records from the maternity database, and we couldn't find a documentation of these discussions in any of the clinic records. The survey results was good. So women did say that they knew about most of the questions, and they were given options for decision making and time for decision making. So standard 3 was about analgesic options. So but the audit results was 0%. So there was no documentation about whether the discussion was made. On the survey, it is still poor and it is still not 100%, but many women did know about what are the options available in the unit. And we found that we were not offering water birth to women. About 18% knew about the option. Women should be asked about the preferences. About format of information of induction of labor was a standard 4. So in audit, it was not a question in the audit, but in the survey, 13 out of 25 women said that they would like to have a video stating how the induction of labor is performed, and a website for 5, and leaflets was okay for 7 women. So overall, we found that in the audit, so we are failing to achieve the target. And the guidelines suggest that we have to discuss the induction from as early as second trimester and continue that discussion every time when we come to the neonatal clinic. So the audit states that we are not documenting, or we are, sometimes we might be talking about this in the clinic, but we are definitely not documenting that. In the survey, there are some good experiences from the patient in different matters, like opportunity for shared decision making as well as analgesic options. But then it is still underway, and we have not attained 100% even in the survey. So we found that the non-compliance reflected in the audit can be due to lack of documentation, because the survey did say that its survey results are better than the audit results. So if we understood from this study that even though induction of labor is being carried out for different reasons in the department, it's also very commonly done, women still are not adequately informed about this. And this has resulted in poor birth experience in the mother, because they come with unexpected decisions, and because sometimes inductions will fail, and then we have to discuss cesarean section to women, and most women are not aware of those things. So they are significant, important milestones in the woman's life. So obviously we have to make every necessary steps to make them informed of their decision. So we have put forward recommendations to practice. So one is to familiarize the staff about the 4 quality standards and what all we need to discuss in the department about for a woman who is having induction of labor. Then secondly, provision of information about all aspects of induction of labor should be made during very early during the antenatal visits, and should be repeated every time in the clinic, so that it's not given as a surprise for the women in the 3rd trimester. So to allow more time for the women, so by doing this as early in the 2nd trimester, they will have that discussion with their partner and family as well. And documentation was provided as a red flag the department, because nobody is documenting the discussion with the women. Then continue to provide patient information leaflet, then encourage discussion and questions from the women all the time. And shared decision making is very important, because that should be allowed between the healthcare professional and the women. So we have made a plan after these recommendations to re-audit after 1 year, and hopefully we will achieve a good percentage from the audit in re-audit as well. So these are my references, and that is the presentation. If you have any questions, I'll take it now. Thank you.
Thank you, Dr. Lakshmi Jairaj, for your wonderful presentation. Does anyone have any query?
Dr. Jairaj, Ricky Grisson here. Do you have a strategy also for making it national standard for conducting these audits?
Yes, so currently it's only regional for us. So it will be expanded onto it in the future, because this is a national guideline anyway. So everybody should be following that. So I think it's easier to do departmental and regional first in different regions, and then collate the findings and submit that to the basically changes to the college is what we have decided to do in the future.
And because I'm not familiar with it, you would say that it's fairly easy to, at least coming from the U.S., it's not that easy, but it's fairly easy for you to get these kinds of guidelines adopted federally.
Yes, so NICE guidelines or the Royal College or the RCOG guidelines are followed all through the England. So obviously we have different regions based on different health boards. So we are from North Wales, United Kingdom. So we have 3 universities in North Wales. So what we usually do is to audit first regionally or locally first in the hospital, and then we do the same audits in the same hospitals under one university, so that it is regional then, and then we do it nationally as well. So that is how we do, and we draw the findings from those, and then we submit that to the college, to the national wide platform, whether it is a NICE guideline or whether it is an RCOG Royal College guideline.
Sweet. Good luck with that.
Oh, thank you.
I hope there are no more questions. Thank you once again, Dr. Lakshmi Jairaj, for your wonderful presentation.
Thank you. Thank you.
So let's move on to the next presentation. The next presentation is by Dr. Ricky Gresham from Lifespan Academic Medical Center from United States of America. Hello, Dr. Ricky Gresham. Are you ready with your presentation?
I am. It doesn't look like the share is available though.
Yeah, actually, I have to make you the presenter. So yeah, I gave you the access now. Please click on the share button to share your screen. Please click on the share button. As soon as you click on the share, yeah, yes, your screen is visible. Yeah, it's
All right.
perfect. Please.
Thank you all for this opportunity, and thank you to the conference organizers for this opportunity to present here at the Third International Conference in Obstetrics and Gynecology in Rome, Italy. My name is Ricky Grisson. I'm an assistant professor in pathology and lab medicine at Brown University and the director of clinical chemistry services at Lifespan Academic Medical Center. What I want to present to you today is our validation study of the insignificance of race in prenatal biochemical screens for fetal anomalies, a study that was conducted by myself and my research assistant, Samantha Seta, who interestingly started out as a clinical lab assistant in our laboratory and then went off to the College of Osteopathic Medicine at the University of New England and is now a second year medical student there. So I have no pertinent financial disclosures to make. And just by way of background, what we're going to do is introduce you to racialized algorithms as a source of structural racism, right? To review prenatal biochemistry, deracialized validation efforts. I'll review several clinical cases from our validation and then highlight other published deracialization efforts in prenatal testing. You know, back during the pandemic, at least here in the US, a very hideous murder took place in Minnesota, where you may know about it, where George Floyd was killed by a police officer who kneeled on his neck for upwards of 9 minutes. That initiative actually sparked a number of medical students who at Berkeley were who were investigating the biologicalization of race in medicine. Their feeling was that using race as biology was a source of structural racism in clinical medicine. And this killing of George Floyd essentially galvanized them to form what's called the Institute for Healing and Justice in Medicine, a nonprofit institute at Berkeley and UCSF that basically has galvanized medical students, physicians, and patients from across the country in order to look at racialized clinical algorithms and remove them from systemic use. Turns out that at that time, a number of articles were published in the New England Journal of Medicine, really looking at examples showing that these racialized clinical algorithms were essentially hidden in plain sight. Many of them, including the estimation of glomerular filtration rate, was one example. BMI risk for diabetes, the FRAX score, and looking at potential for osteoporotic fractures. Pulmonary function tests actually have an adjustment for race and ethnicity, and JNC8 hypertension guidelines. And there are a number of these that the U.S. has been keen to act on, and has ultimately been a cause of a driver of racial disparity here in the United States. And so there have been efforts to eliminate these algorithms from clinical practice. As a laboratory medicine physician, my job is to make available clinical laboratory tests for the diagnosis, management, treatment, and prognostication of disease. But also as a public health practitioner, I think that deracializing these clinical algorithms fall within the core functions and essential services of my role as a public health agent, right? And our public health system, as behind as it is, has actually adopted 10 essential services, a number of which involve what we do here in the laboratory, and a number of core functions that we can exploit in order to deracialize these clinical algorithms. And so what I want to do is talk to you now about our racial adjustment in prenatal biochemical screening for aneuploidies. And I'll start by reviewing just a little bit of how we use prenatal biochemical screens in order to screen for Downs, trisomy 21, trisomy 18, and trisomy 13. You know, Down syndrome was described in the mid 1800s by Sir Langdon Down based on the clinical facial features of the case subject. But it wasn't until the 1930s where Penrose actually showed uh, age to be associated with Down syndrome risk. And in fact, the first screening test for Down syndrome was age greater than 35. The physician would just ask the question, how old are you? If you're older than 35, you actually have high risk of Down syndrome. If you're less than 35, you actually were considered low risk. And at that time, the detection rate was about 51%, and the false positive rate was about 14%. Right? This was before we actually even discovered what chromosomes were. In the 1980s, actually, it was fast forward to that situation remained the case until the 1980s, when it was discovered that low second trimester AFP and several more second trimester markers were added and could be used to revise the assessment of Down syndrome risk. At that point, improving the detection rate to about 80% and the false positive rate to 5%. And then later in the late 80s and early 90s, first trimester combined testing was shown to have similar performance as quad testing, where both first and second trimester testing could be combined as an integrated screen. And that integrated screen would actually have a detection rate of about 90% and a false positive rate of about 2%. Now, we have moved on from that, but there are a number of settings where this prenatal biochemical screen is still the standard of care for picking up fetal aneuploidies, right? Now, when we are using the biochemical screens to pick up Down syndrome, the characteristic pattern, this is just a gestalt, the characteristic patterns of the first trimester markers is that PAPA is decreased, beta HCG is elevated, and the nuchal translucency is elevated significantly. With the second trimester markers, AFP and unconjugated estriol are decreased, whereas the HCG and inhibin A are elevated. And you could actually also diagnose Down syndrome based on the physical presentation of the baby at birth, where they will have epicanthal folds and a fat facial profile, this transverse palmar crease, or so-called simian crease, abundant neck skin, which we could pick up as the increase in the nuchal translucency, congenital heart defects, intestinal stenosis, a hypotonia, and a so-called sandal gap, right? Additionally, we can use cytogenetic testing to pick up this extra chromosome 21, to pick up the Robertsonian and other translocation types, and to identify mosaics. Trisomy 18, on the other hand, has also some characteristic clinical and biochemical features. The first trimester markers, the biochemical markers, are all decreased, and the nuchal translucency is elevated. Whereas in the second trimester marker, second trimester, all of the markers are decreased, and inhibin A is about equivocal, right? But again, you could use the physical presentation of the baby or cytogenetics in order to make that diagnosis. Micronathia, mental retardation, low sedation, a short neck, renal malformations at rocker bottom feet, right? And then for trisomy 13, there are indeed characteristic features, but the screening performs less well. The first trimester markers are decreased with an elevated nuchal translucency, but you can see that the second trimester markers are all equivocal, right? And these babies, when born, tend to have polydactyly, microphthalmia, microcephaly, and mental retardation. They can have cleft palate and lip, cardiac defects, umbilical hernia, and rocker bottom feet. And again, you can diagnose it by a karyotype. So what we did in our study was basically, there are several variables that are considered critical for calculating fetal risk assessment for aneuploidies and open neural tube defects. And these variables have been characterized over time: maternal age, history of insulin-dependent diabetes, tobacco use, open neural tube defect history, aneuploidy history, IVF, pregnancy, race, weight should be in there. It turns out that our body, the College of American Pathologists, basically mandates the use of race as a correction factor for laboratories performing prenatal biochemical screens, right? And they have limited it to just a black-white dichotomy, but in our system, we actually use black, white, East Asian, South Asian, and Hispanic, Latine ethnicity. But the issue here is that, race is a sociopolitical construct without a biological basis, and there's limited justification to include race as a parameter in medical algorithms. And what we propose is that we assess the role of race in prenatal biochemical screens by calculating the risk of fetal anomalies while varying race and ethnicity. And we aim to assess the clinical performance of race-based prediction through comparison with anatomical ultrasound, cell-free fetal DNA screening results, amniocentesis karyotypes when present, and patient outcomes at delivery. Right. This took place in our largest academic medical center in Rhode Island, Lifespan Academic Medical Center, it happened there because we provide testing for the vast majority of OB/GYN practices in Rhode Island. And the prenatal biochemical screens that we provide are sequential integrated tests, NT quads tests, and maternal serum AFPs. We have a standardized patient demographic form that we use to collect data, and we collect a significant amount of data: race, number of fetuses, maternal gestational age, all of the required elements for the risk assessment. We also ask our residents and fellows to collect ultrasounds, genetic history, cell-free fetal DNA results in the case that the patient has cell-free fetal DNA, and birth outcomes. And these are all requirements for ongoing proficiency testing and meeting regulatory guidelines. We also archive these specimens, enabling offline testing to keep the database up to date. Right. So what we decided to do was a retrospective test of convenient but prospectively collective samples. And right now we have a cohort of about over 120 patients, but we've only been able to analyze 95 of them from December 22nd to present, where we If we were able, we collected first and or second trimester specimens. Many of these patients, when they came through, they were getting maternal serum AFPs, but if they were getting torch titers, then we and it fell within the appropriate weeks, then we had a specimen for the first trimester. We're using the LMS Alpha 8 software from the UK-based company, LMS Logical Medical Systems, and our risk calculations were adjusted for gestational age, weight history, and the clinical states as above. Now, what we did here was that since race is a sociopolitical construct, and there are a number of ways that people can be assigned race in our system. Either they assign it themselves, or we don't advocate for this, but the accessioner, the phlebotomist, the person ordering might just say, oh, I think you're black, or I think you're white, or whatever, and assign the race for them, which we don't advocate, but we acknowledge that these things happen, and they happen across the system. And so we felt like we could basically just vary the race and see how the calculations change. We look at the race-based risks as traced on alluvial charts, and we have generated 2x2 contingency tables to assess the outcome. And, from our preliminary findings, what we've been able to see is that for the 95 patients where we're looking at open body cavity and open neural tube defects, we have one case where it was a true positive for open body cavity defect, and we have 3 false positives, and then the vast majority of the cases are negative. To date, we have not found in our 95 reviewed cases case of aneuploidy. And where we have cell-free fetal DNA or cytogenetics, they have all been negative to date. But when we vary the race based on the software, you can see trisomy 13 risk doesn't change when you go from black to white to overall. Trisomy 18 risk doesn't change. However, there are some changes from high risk to low risk when you change from black to white, or white to other, and then to overall, and the same for open neural tube defects. Now, interestingly, we started to review all of our cases, and what we are going to show you here are a number of cases that were available from our review. These happen to be from patients, 32-year-old G5P4 black female, who essentially was a non-smoker, diet-controlled gestational diabetic without a history of open neural tube defect or aneuploidy, but a strong maternal family history of postaxial polydactyly, and that polydactyly could be associated with trisomy 13. Now, she had low risk, and that's a hard marker for trisomy 13, a strong marker. She had low risk for on the biochemical screen performed after the fact, and low risk cell-free fetal DNA. But you can see here that she had polydactyly in her left hand, and when the baby was delivered, the baby had polydactyly postaxial on the pinky fingers, erythema toxicum, and nevus simplex. Now, this baby actually just went to surgery recently to have the supernumerary fingers removed and identified by our anatomic pathologist. And so this was a case of a fetal anomaly where the biochemistries were negative, but it wasn't trisomy 13. As by the cell-free fetal DNA. Now, again, we had a 36-year-old G2P1 who was a former smoker, IVF pregnancy, who also had HSV. This lady had a strong, the father of the baby had a strong paternal family history of polydactyly and syndactyly. And while her biochemical screen were low risk, the ultrasound actually showed that the baby had or the growing fetus had syndactyly in the right upper extremity, and both the right foot and the left foot had polydactyly. That could be associated with trisomy 13 and 18. Unfortunately, the cell-free fetal DNA was negative here, but when the baby was born, it in fact didn't have these anomalies, polydactyly, syndactyly of the right hand. Another case, 23-year-old white female. Now, this one was a bit concerning. She was low risk on the biochemical screens, but that was before we actually were able to secure a good ultrasound. The ultrasound actually had cystic hygroma where the NT, the nuclear translucency, was about 5.74. And we suspect that this would, in fact, if we did it as an NT quad, change this to a high risk, right, pregnancy. Now, it turns out that this baby had the cystic hygroma, intrauterine growth restriction, question of rocker bottom feed, and atrioventricular septum defect. And well, this fetus is still living, but it had persistent growth, fetal growth restriction, being born at 2 percentile. In terms of fetal weight. Now, we have been unable to follow up with this one to get a good assessment to see whether or not physically there is evidence of 13, 18, or 21, but the cell-free fetal DNA performed for this baby was negative. So we are interested in she declined amniocentesis. We have a 36-year-old female, white female, who basically has what I call a type 1 history. There's no issue there. She had low risk biochemistry, but an echogenic intracardiac focus and a bilateral choroid plexus cyst, but there were no abnormalities on her on macroscopic analysis. A 30-year-old Latinx female who had who's the father of the baby had a history of trisomy 21, and despite low risk screening tests, the baby was suspected of having club feet. The infant was born with focal leg clonus and distal metaphyseal fractures, but did not appear to have, at least by cell-free DNA, 13 or 18. We did have, however, one case of a 30-year-old white female with a type 1 history who had a high-risk biochemical screen. And on ultrasound, that patient was found to have an open ventral wall defect. In that case, it was gastroschisis. And when the baby was delivered, actually, the gastroschisis was identified and is now undergoing repair. Our two of our cases where we had a 29-year-old female in a high risk by age of 41-year-old female who both had high risk biochemical screens, but who have yet to show evidence of trisomy 21, despite the high risk biochemical screen for trisomy 21. So to date, we don't have any cases of trisomy 21. We only have a case of open body cavity defect, but we're still reviewing our cases to see if we can eliminate race. Now, the effort to eliminate race is not just something that we are doing in our institution, but there are a number of institutions across the U.S. That are doing it, and doing it for open neural tube defects, right? You know, open neural tube defects are, severe congenital anomalies resulting from failure of the neural tube to close or reopening following closure. And open spina bifida, anencephaly, and cranioracheschisis are the kinds of conditions we're concerned about. Now, AFP has been a mainstay for picking up neural tube defects, having been founded in 1956, having been used for screening for neural tube defects and diagnosing neural tube defects in 1970s, and then having been modified with acetyl amniotic fluid acetylcholinesterase as a confirmatory marker for neural tube defects in 1981. The maternal serum AFP can be effective at distinguishing unaffected patients from those with open spina bifida and anencephaly, although there are some false positives and often some false negatives. AFP levels have a number of determinants, both physiological, maternal demographic, and pathologic. Now, interestingly, published at the University of Washington in Seattle, there were some researchers who decided that they wanted to reconsider the role of race in adjusting prenatal biochemical screens. And what they did was they reviewed 43,000 of their patients in the medical record from their system that had been in place from January 2007 to December of 2020. And there, basically, they looked at patients who were self-identified as Black or non-Black and took what we would consider all type 1 cases, meaning these were patients who had complete records, they were non-diabetic, non-smokers, they were in the appropriate age, they were in the appropriate gestational age, and they had they were non-IVF patients. And what they discovered in their study was that, from their baseline data, the maternal age of Black women compared to non-Black women was significantly lower, but just slightly. The maternal weight, Black women were heavier than non-Black women. The gestational age was about 123 days versus 120 days for non-Black women. And the raw MSAFP, which is the unadjusted MSAFP, was about 41 for Black women and 37 for non-Black women. Now, when they looked at gestational age based population nomograms to see how the AFP differed, they showed that no difference between Black and non-Black individuals in terms of their maternal serum AFP, both in the raw maternal serum AFP values and in the mean maternal serum AFP values by their regression model. Additionally, and so from their study, last slide, what they were able to say was that that this modern race-free model actually shows no racial difference in all of these type 1 cases, while the lab-derived model actually shows some difference, but it's not clinically significant, right? And so what we are aiming to or hoping that we've been able to show is race as a sociopolitical construct doesn't have pertinent biological basis, especially in prenatal biochemical screens. That varying race in aneuploidy biochemical risk assessments appears to have little impact on risk outcomes, although we still have some a chart review to finish, that using modern statistical techniques to assess race in open neural tube defect and biochemical screens actually shows no difference when race varies, and that race should be removed from biochemical screens for fetal anomalies. Okay, and with that, I'll take any questions.
Thank you, Dr. Ricky Christian, for your wonderful presentation. Does anyone have any query?
All right, thank you all.
Okay, let's move into the next presentation. The next presentation is by Dr. Osmane Silva from National Office of Reproductive Health, Mali. Hello, Dr. Osman. Are you ready with your presentation? Hello, Dr. Osmane. Are you ready with your presentation? Hello, Dr. Osmane Silva. Are you ready with your presentation? Kindly unmute yourself. I think there is some technical issue with Dr. Osmane's end. So let us move with the further presentations. The next presentation is by Dr. Raj Gopalan, CEO and founder of BSRM Consulting, United States of America. Hello, and this is a keynote presentation. Hello, Dr. Raj Gopalan. Are you ready with your presentation? We are unable to hear you. Kindly check your microphone settings.
You hear me?
Yeah, now you're audible.
Thank you.
I'm making you the presenter. Please click on the share button to share your screen.
Okay. Let me know if you can see my screen.
Yes, your screen is it's perfect. Yeah,
All
it's
right.
perfect.
Thank you. This is Dr. Raj Gopalan, and really thank you for the opportunity to be able to present this to this audience. Really excited about it. What I'm going to present is the ovarian cancer, as you know, is a silent killer. Can artificial intelligence and machine learning help to predict the risk early? So that is the topic of my presentation. Just to give a brief bio of me, I am an internist by training, and I have worked mainly in the provider space in the United States, starting at National Cancer Institute, NIH, and followed by University of Maryland, University of Pittsburgh Medical Center, and the University of North Carolina Hospital Systems. And finally at the Adventist Health Systems, which is a multi-hospital delivery network. I have also been involved in medical informatics. I'm formally trained as a medical informaticist, especially on AI and machine learning. And I did my fellowship at the University of Pittsburgh Medical Center for that. And I work for health technology companies like Wolters Kluwer and Siemens Health Systems. Currently, I have my own company, consulting company called BSRM Consulting, where I provide consulting services, especially for clinicians taking care of the patients, especially primary care physicians, ED physicians, especially helping them how they can use medical technology to be able to make their life much more easier and make it more productive and more effective. So that is my current role. So currently I want to talk about ovarian cancer and how we can actually predict the risk for it. As you know, ovarian cancer is 10 times more deadly than breast cancer, and pap smear do not detect ovarian cancer. So, and there are no current screening tests for ovarian cancer. So another important thing is that 70% of the cancer are not detected. Ovarian cancer is not detected until stage 3 and stage 4. So what is the significance of that? If you look at the survival rates, if you detect ovarian cancer in stage 1 and stage 2, the survival is 90%, whereas stage 3 and stage 4, survival kind of drops from 90 to 28%. So, which makes it extremely important to identify and detect ovarian cancer very early, because once you detect it very early in stage 1, it's completely curable by surgery. So that is why it's extremely important to identify the risk for ovarian cancer very early. There are a number of factors that are responsible for ovarian cancer, like age, obesity, family history, medical conditions like endometriosis, hormone replacement therapy, and so on and so forth. Even though the incidence of ovarian cancer is only 1 in 1,000. So if I randomly, grab a female during the reproductive age, or maybe between like 30 and 90, the chances of that person developing ovarian cancer or having a risk for ovarian cancer is only 1 in 1,000. So how do we detect ovarian cancer very early? So I want to just switch gears and talk about blood, because my talk is going to be how can we detect ovarian cancer very early using routine blood markers. So Your Blood Never Lies, which is a famous book by James Laval, because blood has got so much information and we have barely scratched the surface. Because as you know, blood circulates through the body about 100,000 times, especially from head to foot, perfusing all the organs of the body and collecting waste products. So it has got so much of information that we have not, even begin to understand the importance of it. And it is one of the most objective data that can be gathered from the blood. So blood, I say this because blood is actually a window to human health and wellness. So this presentation is going to be focusing on blood and how we will be able to detect, ovarian cancer early. So this is a famous brain-to-brain loop concept that was proposed by Charles Lindbergh. So as you know, as a clinician, I'm an internist. So as you know, we are ordering a number of tests today. So about 14 billion tests are ordered every year, and 70% of today's medical decisions depend on lab test results. Believe it or not, that is the CDC has said that. So we haven't changed the way we actually assess the blood test results in the last 50, 60 years, because from this, if you look at the patient's brain, so a patient comes to us in a clinic and we evaluate the patients based on the symptoms, signs, personal history, family history. Then we did a detailed physical examination, and then within our head, we kind of formulate a differential diagnosis. And based on that, we order a bunch of tests. This is just a manual process, has not changed. And once the blood is ordered, then the rest of the stuff has been extremely automated in today's world, because analysis consists of advanced analyzers and robotics and pneumatic tube systems and things like that, and barcoding and things like that. So it is extremely automated. So as you all know, the blood results we get it back within reasonable time, 3 to 4 hours. In case of stat, within about 30 minutes. And it is consistent. Even if you send the blood to multiple labs, the results come comes back consistently within like a very small percentage of error. So once the results come back, the physicians are actually looking through the blood test results. Nowadays, there are so many, we order like panels, 30 to 40. And the physicians look through each one of those tests and see if there is any one of them is highlighted, whether it's high or low. And if there is no highlights, we just say that, okay, everything is good, come back after some time. But that is not the way it should be practiced, because the way the reference intervals is coined is really interesting, which I want to talk to you about. So one of the main things is about 29% of the diagnoses we are making today are wrong diagnoses, which results in, extension of the patient stay, unnecessary test, morbidity and mortality, and there is a, multi-billion-dollar lawsuits that are being, that happens today in the practice of medicine. So how can we kind of address these things? I talked about the reference intervals. The reference interval is actually, came up with, it's an interesting story, because the way it is done is that about 100 self-declared volunteers, blood is collected. And who are those volunteers? Self-declared healthy volunteers. And how the blood is collected, and who are those volunteers? These volunteers are medtech, because those are the people who can easily be accessed, people working in the labs. And then, they tested the blood and created what is called a bell-shaped Gaussian distribution. And then they took 2 standard deviations, which is only 95% as the reference intervals. And interestingly, this doesn't involve, so I'm going to tell you in the next slides, that it only includes a limited population. So if you are going to negate, or if you want to predict a negative diseases, then you're going to only take into account, 1 standard deviation, which will be much more accurate. So if you're going to rule out a disease, then you have to take actually the entire spectra, more than 2 standard deviations, so that you'll be able to confidently say that this patient is free of disease. So this thing is not really very clear for practicing physicians. They just go blindly with the reference intervals, and then unless it's highlighted, they don't take action. But imagine if you have number of lab test results riding on the edges, either high normal or low normal, does that really mean the patient is normal? So that's exactly what you're going to see with the AI and machine learning. So one of the things I also want to point out is that high proportion of the reference interval, 79%, was excluded, because individuals 60 to 79 years old is not included in the construction of the reference intervals. As you know, majority of the diseases are common in the older age group. So reference interval is actually worthless for older people. So that's kind of interesting. So it has been found out that we are only using 95% by 2 standard deviations, but if you increase it to 99%, that will decrease the false positive by almost 5-fold. Okay, this is just a schematic about one of the models that we use for machine learning. So what I'm going to talk about is that, can we identify the risk for ovarian cancer? I'm going to focus on ovarian cancer because I've done research on multiple cancers and chronic diseases. Let's just focus on the ovarian cancer. And the multiple models are trained with routine blood markers, which include total count, differential count, a lipid panel, electrolytes, and then identify whether the patient has any risk of ovarian cancer or not. This is based on thousands of patients who had been diagnosed with ovarian cancer and looking at their blood profile up to 3 years before they were diagnosed with cancer. So the whole idea is that, is it possible for us to find the risk for ovarian cancer up to 3 years before even the first symptoms appear? So that is the idea here. So we have tried multiple models, and this is one of the best performing models that I want to show. And it has got, as you can see, the ROC curve of about 97.7%, which means that, as you can see here, the area under the curve is 97.7%, which means that it corresponds to the accuracy, how well the model did, the artificial intelligence model did. And it also lists what are all the blood parameters of importance across those. So what we did was we actually used about 8,000 patients, about 7,000 to 8,000 patients, divided into half. 4,000 patients had ovarian cancer, 4,000 patients didn't have ovarian cancer. This is just control. And then we trained a network, artificial intelligence, machine learning networks, to identify the blood profile that have got high risk for cancer using actual patient who has developed cancer, and then going back up to 3 years of their blood test profile, right? And based on that, what it came back with a list of markers that are kindly important for identifying the risk, which includes age, sodium, alkaline phosphatase, glucose, MCV, MCH, ethnicity, calcium, potassium, basophil count, lymphocytes count, so on and so forth. As you can see, the taller the bar, the more important the value is. And then one of the important thing is that, okay, we trained it, we got a very high performing model, but if I'm going to use the model, so mainly this is being used for screening, which is important, because when we are screening, what we need to do is that, the chances of finding ovarian cancer is 1 in 1,000, which means that we cannot afford to even miss one patient having a risk for cancer. But it is okay to have false positive, because there are a number of tests that can follow that in terms of ultrasound, CA-125, and there's a number of tests that can be done, right? So the whole idea is that, is it possible to identify patients who have a high risk, and then we can actually recommend a CA-125 test for them and additional testing so that we can kind of confirm it. So here, after we trained it, we test it. When we testing it, we want to actually make the population similar to a screening population, which is 1 in 1,000. So in this particular case, as you can see, there are about 1,300 patients with no ovarian cancer, and there are only like 13 patients with ovarian cancer, which makes it about 1 in 1,000. So the model is able to perform with an accuracy of 97.82%, which means that, as you can see here, so when the patient doesn't have ovarian cancer, it actually predicts with about 99.9% accuracy, which has got a very, very high negative predictive value, which is what we want when you are screening, right? And it has got a positive predictive value is only 30%, but that is okay because the population has extremely high normal and only very small, 1 in 1,000, as I said, ovarian cancer. That is why the positive predictive value is low. But the important thing to look at is the negative predictive value and also the sensitivity and specificity. As you can see here, the sensitivity is 92% because out of the 13, it only missed one patient. And on the other hand, for the normal patients, it actually performed very well with 97.8%, correctly identifying is no ovarian cancer. So this is a really good screening tool. And this can actually, so in this particular case, it's going to label those 28 patients also as having ovarian cancer, but that is okay because then they will go through CA-125 and ultrasound to rule that out. And then this child obviously, will undergo all the different tests. So that is the point of this. And in addition to the general markers that I talked about, the model also tells you for each and every patient what markers was considered to be important. So in this particular case, this is one of the example patients, ovarian cancer, and it came back and said sodium was a very important marker that actually pointed to this patient being an ovarian cancer patient, risk for ovarian cancer and MCH. And there are also other markers which contradicts. So ultimately, some markers will actually support, some markers will contradict, and the sum total of the model comes up with a prediction. And in this particular case, the sodium and the MCH was so prominent that it was able to come back with a 96% confidence that this patient is ovarian cancer. And on the other hand, there's a patient with no ovarian cancer. As you can see, it took into account age, bilirubin, ALT, alkaline phosphatase, glucose, and basophils. and came back with an accuracy of like 94% confidence that the patient doesn't have ovarian cancer. Okay, so this is like 4 patients with example patients that it actually diagnosed correctly whether the patient has ovarian cancer or not, with a confidence of about 0.9, 0.91, and 0.85, and then no ovarian cancer with a confidence of 0.7, because it's the ovarian cancer of 0.3, so no ovarian cancer will be 1 minus this. And then each patient, it comes back with what are all the important top 3 parameters that are taken into consideration. So in this particular case, a white patient, the 58 years old, it considered the ethnicity and MCH and neutrophils. And the second patient, again, the same thing, but MCH is dropped. It took into account age, ethnicity, and neutrophils. And then the third patient, as you can see, sodium and calcium was taken into account. So the reason why I'm saying this is that this is the new era of AI and machine learning, because previously AI and machine learning was considered as a black box, which means that it'll give you a right answer, but it won't tell you why it arrived at an answer. But as a clinicians, we would like to know, instead of just saying a risk, we would like to know more information about how is the risk being calculated and what are all the parameters that went into in coming up with a risk score. So that is what is called an explainable AI. So it's no longer a black box, and we are trying to make that as a glass box so that you can actually look into the box of the model and see what exactly it is doing. That is why this actually gives you back with additional information about what is considered in arriving at the results. So if I look at the 8,000 patients and then find an average about each of those markers, as you can see, there is an important difference between the sodium being high, the red being the ovarian cancer patients, and the blue being control patients. So there is a big gap between that. So sodium is shown to be have an impact. It's actually average sodium across multiple patients. ALP, as you can see, is lower in this particular cohort, and then glucose is actually lower. So this is another interesting thing, because sometimes what happens is glucose is actually utilized by the cancer cells, and the results that the glucose may be lower. That doesn't mean that they don't have a risk for cancer. In addition to that, sometimes people who are diabetic are also on anti-diabetic drug, so their glucose may be lower. That doesn't mean that the risk is lower. So that is why you're actually seeing that contrast. And here again, potassium, there is a difference in the potassium, there is a difference in the calcium, as you can see. And I only just gave you an example of a few of the markers. Again, the risk that is put forward by the model is not based on 1 or 2 markers. It's a combination of all the markers. So that's kind of important, because sometimes some will contradict, some will support, as I said in the previous slide. So it's a sum total of that. Okay, now another important thing is that we need to provide additional references and additional information about what has sodium to do with ovarian cancer. So if you look at the literature, there are a number of studies. So a study that has found out a link between high consumption of sodium and an increased risk of lung cancer. So I have all the references here. And excessive sodium intake has been suggested to increase the risk of stomach cancer. It has not been studied in ovarian cancer, but that may be something that is a potential study that can be done. And one study evaluated the alteration in the serum sodium levels in women with ovarian cancer and found a significant relationship between serum sodium levels and the disease. There is another study that highlighted the prognostic value of preoperative hyponatremia in patients with epithelial ovarian cancer, indicating the potential impact of serum sodium levels on patient outcomes. And there is another research that has identified inhibitory effect of sodium molybdate on the growth of ovarian cancer cells through inducing both pheroptosis and apoptosis, suggesting the potential mechanism of action for sodium compounds in influencing cancer cell behavior. Additionally, voltage-gated sodium channels have been proposed as a potential biomarker and therapeutic targets for epithelial ovarian cancer, indicating a role for sodium channels in progression of the disease. Okay, then what about alkaline phosphatase? We saw that there is a difference between ALP between high-risk ovarian cancer patients and controls. Elevated ALP levels have been associated with early diagnosis of ovarian cancer, as demonstrated in a case of endometrial ovarian carcinoma. Further, research has indicated that ALP activity can be a marker for ovarian cancer stem-like cells, which is called CSLC, and the patients with greater ALP expressions are related to advanced clinical stage and have a higher risk of recurrence and lower survival rates. So even this paper suggests that if the patient has a high ALP, it's important that you may consider running a CA 125 and even an ultrasound for those patients. It's worthwhile. That ALP plays a role in regulating aggressive potential of high-grade serous ovarian cancer cells via a non-canonical WNT pathway. So I have a paper on that. It's an extensive paper that talks about it. Suppression of ALP activity has been shown to inhibit the self-renewal and tumorigenicity of ovarian cancer cells, suggests that ALP might be a therapeutic target for women with ovarian cancer. Additionally, placental type alkaline phosphatase has been measured in sera, cyst, and ascites fluid, as well as tumor extracts obtained from gynecological cancer patients, particularly those with cancer of the ovary. So that kind of gives you, information about why ALP should be considered in the risk for ovarian cancer. This actually supports the model, the ML model, that it's not just, taking this risk out of nowhere, because it's based on a solid science. Okay, now the role of glucose. We all know that increased expression of glucose 1, a glucose transporter, has been observed in ovarian cancer, indicating a potential role of glucose in the disease. So diabetes-related high glucose levels have been associated with an increased risk of ovarian cancer, and diabetes may make ovarian cancer harder to treat and worsen the outcome, which is pretty characteristic because the cancer cells actually love feeding on glucose, so it actually enhances growth in metastasis. So high insulin levels. Another thing about diabetic patients is that in addition to the glucose, they also have a very high insulin levels, and some of them are insulin resistance. And that can lead to chronic inflammation. And of course, chronic inflammation is the precursor for any type of cancer, especially ovarian cancer as well. So a systemic review and meta-analysis of the cohort and case control studies also demonstrated an association between diabetes mellitus and the risk of ovarian cancer. So another one called the Warburg effect describes the ability of fast-growing cancer cells to potentially metabolize glucose via anaerobic glycolysis rather than oxidative phosphorylation, highlighting the altered glucose metabolism in cancer cells, including those in ovarian cancer. So these are all suggestive of glucose being an important factor, and especially if you are a diabetic patient, it's extremely important to monitor them for ovarian cancer risk. So the role of MCV, MCH, RBC, and RDW, which are all related to red blood cells. So high MCV and high MCH levels predicted poor outcome for patients with gastroesophageal carcinoma, indicating a potential prognostic role for these hemorrhagic parameters in certain type of cancer. Studies have not been done for ovarian cancer. It may be worth looking into. The hematopoietic parameters, including MCV, MCH, can serve as an indicators of systemic inflammation, which I said in the previous slides that may be a precursor for ovarian cancer. So MCV, MCH definitely kind of points to the risk of inflammation, metabolic alteration, which could be a precursor for ovarian cancer. And I think probably this last slide, the role of potassium. Research has indicated that a potential association between potassium levels and ovarian cancer. Elevated serum potassium levels are attributed to factors such as chemotherapy, which can cause cell lysis and release of intracellular potassium into the blood and extracellular fluid, resulting in a high potassium. There is a particular potassium channel called E potassium channel have been identified as a potential prognostic marker in ovarian cancer. High expression of E potassium channels has been associated with poor prognosis in patients with ovarian cancer, suggesting a potential role for potassium channels in the progression and prognosis of the disease. The third one is blocking voltage-gated potassium channels have been investigated in ovarian cancer cell lines, demonstrating their potential role in cell proliferation and as a therapeutic target for treatment of cancer. Lastly, calcium. We have seen the difference between the calcium levels between the control and the ovarian cancer risk patients. Calcium ions have been shown to play a role in promoting cell proliferation of ovarian cancer and are involved in apoptosis processes. Calcium signaling has been identified as an essential component of various aspects of cancer, including ovarian cancer, and has been proposed as a potential target for anti-cancer therapy. Moreover, pre-diagnostic serum calcium levels has been associated with an increased likelihood of being diagnosed with and dying from ovarian cancer as indicated by the nested case control study. Another longitudinal study also found that women who develop ovarian cancer show an increased serum calcium level. And alterations in the calcium ion signaling, including the expression and effects of various calcium channels, have been associated with ovarian cancer cell proliferation, cell cycle progression, apoptosis evasion, and tumor growth and metastasis and drug resistance. So, in conclusion, medical science, if you look at the medical science as a book, if you compare that into a book of like 1 million pages, we have only read the first 100 pages, which means there are so much yet to be discovered. And one of the advantages of machine learning is that it'll be able to give us correlations between certain markers and certain cancer, so that can open up clinical research. So in this particular case, it gave us a lot of information about the role of glucose, the calcium, alkaline phosphatase, and ovarian cancer, and also gave us some mechanism of action. So this will actually open up various opportunities for clinical research. In addition to that, we can also do additional retrospective studies using these models, whether it is able to diagnose, able to predict the risk for cancer. So one of the key thing of using routine blood markers is that we all get our routine blood markers done once in a year during wellness exams. So that is available. So that is an extensive amount of data that is available. Can we use that to be able to identify risk? So that is the work that I've been doing. This is just ovarian cancer. I've done work on uterine cancer. I've worked on lung, colon, the liver, even like Alzheimer's, chronic kidney disease, and the whole flurry of stuff that I've done. And there is, I see a great potential in the machine learning models to identify the complicated profile of blood markers, which is a multidimensional problem that a human being like a doctor will have difficulty trying to assess that, because we can only look at 3 axes or 3 dimensions. So if it had 40 tests means it's got a 40 dimensions, it's very difficult for a human to be able to identify that. That is where the machine learning comes into play. They can do a phenomenal job of multidimensional data analysis. So I just want to stop here and I'd like to take any questions, comments, or suggestions. You can contact me at raj.gopalan@bsrmconsulting.com. And it has been a pleasure to share this with you all, and I'll take some questions.
Dr. Gopalan, this was a really good talk. We have a number of experiences with these machine learning models, looking at generic test results that ultimately are predictive of things. It flourished during the pandemic when people were trying to get a handle on the COVID testing. COVID testing was very limited, and it was difficult to manufacture it fairly quickly, and there were reagent issues, and so these kind of generic models flourished, right? So I like this in part because it tries to find the needle in the haystack, right? Do you have plans to work with institutions like I'd say our institution, Lifespan, or Care New England, would be very interested in trying to assess your model as a way to pre-identify patients who might be at risk and use more advanced testing, Overa Next, Roma score, or even more advanced testing to try to figure out who's really at risk. Are you up for an opportunity like that?
Absolutely, absolutely, Dr. Grison, thank you so much for that. I just want to add what you said about COVID. We have actually developed a model for COVID to identify risk for all the patients. We looked at all the patients with RT-PCR positive patients, and then trained the model with patients, because we had a fortunate enough to get patients from New York, from Houston, from Spain, and we pooled about 6,000 patients who ended up with either respiratory failure, multi-organ failure, and even death. And the whole idea was, does the model be able to predict the risk for any of this, right? Like, respiratory failure and things like that, especially when COVID was really rampant and people were trying to turn away because the beds are all full, the ICU was overflowing. So the model was able to predict with 80% accuracy whether this patient will go in for any of those complications. So the idea was, and then, we tested that. We built the model even before the vaccine was available. And then we tested that with patients who are partially vaccinated, fully vaccinated, medicated, and things like that. The model was still able to perform, even though the training was done way before the vaccination. And I want to say this because the blood profile actually assess, because if the patient is vaccinated, the blood profile will change to a lesser risky profile. So the model doesn't need to know about whether the patient is vaccinated or not, whether it's what kind of a variant of the COVID it is. It's a Delta or Omicron or something like that. The blood parameters is able to give the model enough information to be able to assess the risk. And another thing that I want to talk, because your presentations on the ethnicity, which is very, very interesting, because we tried with models without actually ethnicity, providing the models while training with the ethnicity information, because it's not universally available. It's because it's an optional field in the electronic medical record. So we were able to find that the model is able to identify that, because I think even the blood profile has a unique signature based on the ethnicity, and it's able to identify that. It doesn't really need the ethnicity information, because most likely, as you pointed out, it may not be accurate. It may be like assessment, right? Whoever just fills in that. So I want to point that out, and yeah, I would love to do that. I think we can have a conversation after that. We can get in touch with this, and we can explore that opportunity. Yeah, absolutely, I'd love to do that. Thank you.
Thank you.
Any question?
Thank you, Dr. Rajagopalan.
Yes,
Yes.
I
Yes, please.
also have a question. We
Yeah.
have a group of cervical cancer recurrences, and we are interested in investigation machine model. Can we discuss it? And I don't understand. Is your consulting BCRM is free or paid, or how much it cost for investigations
Yeah, I mean, we can definitely talk about
together?
it. Yes. Whom am I talking to?
What?
What's your name? Is it Anastasia?
Yes, it's Dr.
Yes, yes.
Anastasia.
Yes. Okay. Yeah, I'd love to get your contact. Definitely, we can talk about it. I would really like to if you have blood test results, that's all we need. I need the routine blood test results and age and gender and confirmed diagnosis, because we need that for training the model. Either path report or anything like that. I don't need the path report, but I need the confirmed diagnosis of retrospective patients so that we can train it, part of it, and then test it on the rest of it. So I would love to do that. I can do it to you, you know, absolutely for almost free. Just whatever the effort needs to be. This is actually I want to promote this. I want to make it available, and not only make it available, kind of prove this, because for getting an FDA approval, we need to have at least 3 studies. So that because I was also been in an FDA panel for their guidelines for regulating AI and ML models, as you can see a lot in the news. So we just want to make sure that it's important to do this, because there is also one of the important things called responsible AI models. We just want to make sure that it's not biased, It is actually trained on the exact, population that will be used for actually testing or using it. So I would love to do that. So we can, get in touch with each other and kind of explore that.
Mhm.
Is that good? Is that
Thank
okay?
you.
Yeah,
Thank you. Thank you.
you're welcome. Any other question?
Hope there are no more queries. Thank you, Dr. Rajagopalan, for your wonderful presentation.
Thank you, Shirley.
And thank you. So by this, we are moving on to the next presentation. So the next presentation is by Dr. Anastasia Shumakina from Mesh Meshalkin National Medical Research Center, Russia. Hello, Dr. Anastasia. Are you ready with your presentation?
I can't share because I
Yeah,
need to.
yeah, I'm making you as a presenter. Please click on the share button to share your screen. Now, please click on the share
Mhm.
button. Yeah, please click on the share button now. And you can find a pop-up window where you have to choose the entire screen option. Yeah,
Mhm.
screen is visible. Please open your PPT.
Mhm. Is it okay?
Your PPT is visible. Please make it a full screen. It's
Uh,
perfect.
yes, I made.
It's perfect. Yeah, that's
Thank you.
perfect.
Thank you. Uh, mhm. My topic is possibilities for realizing reproductive potential in patients with endometrial cancer with polycystic ovary syndrome and infertility. Endometrial cancer today is also actual problem because of high of morbidity and mortality, and in recent years there has been a trend of increasing incidence in patients of reproductive age, and in this case it's important to carry out organ preserving treatment in women under the age of 40 who are interested in preserving reproductive function. The risk of endometrial cancer directly depends on hormonal and reproductive factors and increases 2 and 3 times in women. There are modern meta-analyses that say about women with PCOS, younger, higher risk of endometrial cancer, and in our Russian data also. So, and first type of, there are two types of endometrial cancer, and first type more frequent at a younger age, and this type consists PCOS, and it's almost highly different adenocarcinomas and better prognosis. The causes of endometrial cancer with women with PCOS is constant stimulation of the endometrium by estrogen in the absence of progesterone. It's obesity, hyperandrogenism, and hyperinsulinemia. Our objective to evaluate the effectiveness of treatment for endometrial cancer in patients with PCOS and reproductive outcomes. We analyzed patients with PCOS and infertility and their endometrial pathology. And let's discuss endometrial cancer. Our standard and clinical recommendation is treatment with levonorgestrel device 6 months and agonists once every 4 weeks with dynamic control. Our Russian data said about high efficiency. It's 96% in patients with atypical hyperplasia and 88% in patients with endometrial cancer. The birth rate was 42%. The relapse rate high in regardless 26% and 36% in endometrial cancer. We had two groups. Group number one, it's hormone therapy. It's 12 patients with endometrial cancer and PCOS. Their age from 21 to 39 years. They haven't got any pregnancy and births, and it's two patients with moderately differentiated adenocarcinoma and G1. Group number two, it's hysterectomy with fallopian tubes, but without ovaries, and with drilling of the ovaries, age from 29 to 44. And this group had pregnancies in anamnesis, and also two groups, G1 and G2. Inclusion and exclusion criteria. Inclusion criteria, it's age of patients up to 40 years, histologically confirmed stage 1 endometrial adenocarcinoma, no evidence of synchronous or metachronous ovarian cancer by MRI or transvaginal ultrasound, no contraindications to hormonal therapy and pregnancy, and patient understanding that it's not a standard treatment and there is a risk of relapse and persistent cancer, that only clinical staging but not surgical means the disease may be more advanced. And exclusion criteria are contraindications to hormone therapy, lack of possibility of further dynamic observation, and history of ovarian cancer in the family or carriage of Belstay mutation. Our algorithm was stage 1 is investigation, hysteroscopy with immunohistochemistry. And it's important to determine progesterone status, sensitivity to further hormone therapy, and absence of ampules in the lymphovascular space. Then we did ultrasound of pelvic organs, abdominal cavity, and lymphatic nodes by MRI, and pelvic organs with contrast, and X-ray of the lungs. Consultations with specialist hematologist, mammologist, vascular surgeon, it's very important for the absence of contraindications to hormone therapy. Stage 2, oncological stage, it's installations of neuronorgestrel containing device for 6 months and agonists once every 4 weeks. Then, after 3 months, hysteroscopy and morphological examinations of the endometrium. Then, also, again, if it possible, we don't take levonorgestrel device in control hysteroscopy and save it. It's very useful for patients, and if it possible, we do it. It's hysteroscopy, but without take out levonorgestrel device. Then treatment by reproductologist. We recommend to implement reproductive function as soon as possible, including the IVM. Then we remove levonorgestrel device, then ovarian drilling or ovarian ovulation stimulation, hormone therapy, and IVM. Let's discuss group number 2. It's patients with hysterectomy with fallopian tubes, but without ovaries. It's an example. It's very important that we did biopsy of ovaries for exclusion metastasis for ovaries. And our oncological results, overall survival after treatment, was 100%. There were no things or relapse or progression. and reproductive results were which group number 1, there are no pregnancies, and group number 2, there are 2 patients with G1 pregnancy and childbirth, and 1 patient on group G2 pregnancy and childbirth. Now we have patients who planned IVF or during hormone therapy. And let's stop in clinical example. It's patient 26 years old with PCOS, endometrial cancer, and primary infertility. There are G2 adenocarcinoma in the polyp. Then we recommend these patients to the Tomsk Institute Oncology, Tomsk Oncology Institute for revision of pathomorphological material, performing a repeat endometrial biopsy under hysteroscopy control, and according to the revision, G2 adenocarcinoma in the polyp and histological examinations, endometrial hyperplasia without ATP. Then concilium, and the decision was organ preserving treatment. Then we did control hysteroscopies. It's this patient hysteroscopy. Then we had a concilium with reproductive specialists, and its attempt was spontaneous conception is recommended if ineffective after 1 month controlled induction of ovulation, short protocol, and artificial inseminations with husband sperm. Then we did laparoscopy, uterine drilling, and insemination. There are pregnancy, during the pregnancy, gestational diabetes mellitus, and it's laparoscopy. In the December of the 2022, in the Regional Perinatal Center, timely surgical delivery during pregnancy, at 37 weeks, 3 days, emergency cesarean section. There are boy, 3,900 grams, 8 and 8 on the Apgar scale, and there is currently no evidence of relapse or progression. Conclusion: when treating patients with PCOS, it's recommended to conduct hysteroscopy and histological examinations to diagnose the condition of the endometrium and identify endometrial pathology before using IVF. In patients diagnosed with uterine cancer and PCOS, it's possible to carry out organ-preserving treatment without violating oncological principles. The decision on pregnancy planning and tactics for managing pregnancy and childbirth is made a consultation with the participations of an oncologist, obstetrician, gynecologist, and reproductive specialist. Thank you for your attention.
Thank you, Dr. Anastasia, for your wonderful presentation. Does anyone have any queries? Hope there are no queries. Thank you once again, Dr. Anastasia, for your wonderful presentation. By this, let's move on to the next presentation. The next presentation is by Dr. Osman Sela from National Office of Reproductive Health, Mali. Hello, Dr. Osman, are you ready with your presentation? Hello. Dr. Osman, there is a lot of disturbance from your side. Kindly check your microphone settings. Hello, Dr. Osman. Can you hear me?
Yes, I hear you.
Yeah, I think there is some network issue or some.
No, please, I'm here. Please let me be hand
Okay,
to share
okay.
my presentation.
Yes, yes. Yes, yes, you're audible now. I'm making you as a presenter. Please click on the share button to share your screen.
Yes, I will share my screen now.
Yes, now please click on the share button. Yeah. Okay.
I I use my smartphone, but
Okay, okay,
uh,
okay, no problem. Okay, kindly click on okay. Kindly open your PPT. After sharing your screen, kindly open your PPT.
okay,
Yeah, open your PPT. Your screen is visible. Kindly open your PPT.
yeah,
Yeah, kindly open your PPT.
so no, I
After
try
sharing,
to share.
yeah, now open your PPT. Please click on the presentation mode and open your PPT.
Just 4 minutes, please,
Okay, okay, sure.
to share with.
Hello, Dr. Osman. Yes, please unmute yourself. Kindly unmute yourself, Dr. Osman.
This
Screen.
conference
I
will
hope
now
the
be
screen is
recorded.
visible from your side.
Yeah,
Okay, please continue with your presentation and please instruct us with the next slide to move the next slide. Okay.
yeah, of course.
Okay, thank you. Yeah, yeah, please
Uh,
go ahead.
thank, thank you very much. It is a real pleasure for me to share our experience in carry out of this program in order to reduce maternal leave and perinatal leave in Mali. In order, we have a program named Maternal Perinatal Leave Surveillance and Response. I will share you the result of this surveillance during 2022. This slide. Uh, the presentation outline in the context, method, results, and conclusion. Please slide. In the context, in the world, every day we have 3,000 women during or after pregnancy or childbirth. In Mali, every day we have 10 women die during or after pregnancy or childbirth. The maternal perinatal death surveillance and response is a model for reduce this burden in community, in health system, in nations. Slide, please. Slide, please. Method is a cross-sectional check carried in 2020 through the weekly active surveillance system of the regional university hospital of Mali. The data were collected through an Excel file developed for this purpose. They were complete analysis of SPSS 20.0 software. Next slide, please. Next slide. We have the result of distribution of maternal leave by region or by structure and probable cause in Mali 2022. We have all region and university hospital. When we have this table, we have Sikaso region and Segu region, which colored on green, which have the more notification of maternal leave. The Segu region come in the first, in the second place, we have Sikaso region. In comparative of the cost of maternal leave, we have in the first, we have 3.
I'm struggling to hear. I don't know if others are too.
Hello, Dr. Osman. We are unable to hear you. Kindly check it with your microphone settings. Hello, Dr. Osman. Can you hear me? Hello, Dr. Osman. Can you hear me? We are unable to hear you.
I already finished
This conference will
the
now be
table one.
recorded.
We can go view the next slide.
Okay. We are changing the slide now.
Okay, this slide presents us the evolution of maternal leave by month. We have on May, during May, October, or November, we have 3 peak of diff during the 2022. That is this analysis allow us to preparedness to face with maternal diff during this month. Please, next slide. Next slide. Mm, we have with figure distribution of seatbelt by type and by region in Mali during last year. When we look at we slide, we constate that uh, we have a lot of diff which okay, next slide. This slide shows us the distribution of seatbelts by region by sleep year and with the probable causes. And we have asphyxia and trauma, which are in the head of seatbelt during last year. And over we can show as the Sikaso region and Sikaso region and Segu region, we are on the head of notification. Next slide. Lisa, please, next slide. We have a distribution of early neonatal diff in Mali. We contest as last slide, Sikaso region and Segu region with Bamako, which are on the on the head of notification of diff. Please, Lisa. Next slide. Uh, uh, to in order to evaluate the efficacy on performance of a system, we have some indicator which are the notification of the number of diff, maternal diff by year. On this slide, we have the notification percentage comparative 2022 and 2021. During 2022, the Menaka region with 1,000 Menaka region, Tombouctou and Ségou, which are on the head of notification. Next slide. That is the same according to the complexness of perinatal diff reporting. Next slide. It is the same as about the notification percentage. We have a reception of a lot of paper to share the notification. We have Mopti and Segu region, which are the with Kai region, which are the head of reception of in our service notification form. Please slide. Next slide again. With this, next slide. This slide show, this slide present the study of implementation of MPDS committee, which is an organ to on the different level, national, regional, on health district, which got a lot of person from different sector in order to find against maternal and perinatal disease problem. We contact with this the number of regional committee. We must, in conclusion, the maternal and perinatal Sylvan make it possible to improve the quality of care, to analyze dysfunction, and to propose approach to be followed to prevent preventable maternal and perinatal death. The analysis of the 2022 data show us decreasing in the number of maternal deaths comparative to the 2021. Also, the report notes an inequality in the condition of OD session in the reporting of OD report at the national level, and this constitutes an obstacle to effort to reduce preventable maternal and perinatal death. Thank you very much. I finish. Lisa?
Okay, that is a
All my
presentation.
acknowledgement to
That is a
all my
presentation
acknowledgement
by
to
yes, Dr. Osman.
I cannot finish. Leave out to share my acknowledgement to Minister of Health in my
Okay, and that is a presentation by Dr. Osman. Does anyone have any query? Hope there are no queries. Let's move forward with the further presentations. Thank you once again, Dr. Osman, for your presentation. The next presentation is by Dr. Nusharat Inamdar from the University Hospital, United Kingdom. Hello, Dr. Nusharat. Are you ready with your presentation? Hello, Dr. Nusharat. Kindly unmute yourself. Hello, Dr. Nusrat. Are you ready with your presentation?
Yeah, hi. I'm ready.
Okay, so I'm making you the presenter. Please click on the share button to share your screen.
Yes, sure. I'll do that. Just give me a minute, please. Share.
Yes, your screen is visible. Please open your,
Yes.
yeah,
You
and
can
make it
see
a
my
full
presentation?
screen.
Yeah, I'll do
Yes,
that. I'll
yes.
do that. Just a minute.
Okay.
Yeah, you can hear that now? Can you see my
Yeah, that's
screen now?
yeah, that's perfect.
Yeah. Good afternoon, everyone. My name is Nusrat. I'm one of the senior registrars in obstetrics in United University Hospitals of Birmingham and West Midlands. Thank you for this opportunity to present a quality improvement project. This is a quality improvement project which was done in University Hospital to improve the awareness and implementation of obstetric anal sphincter injuries. And we did a simple background on this is like The incidence of obstetric anal sphincter injury is quite high because obviously the mode of delivery in 15 to 20% of women here is instrumental delivery, and we try to reduce the instance of cesarean section. So instrumental deliveries at a higher rate comparatively. So using instrumental deliveries do come with one of the cons of this instrumental deliveries are that we do have a lot of anal sphincter injuries, especially when you use a forceps delivery, which has an instance rate of around 7 to 10%. So this study was done to see how we could improve the incidence of obstetric anal sphincter injuries in our trust. And at the start of the study, this was done with my colleague called Aisha Zafar. And this study was done previously. Before the start of the study, we involved midwives and junior doctors who are basically involved in deliveries and instrumental deliveries in our trust. And what we did was a simple background, as I've written here, that it's during the childbirth, it's a common event, and the third and fourth degree is what we are trying to reduce here. Second degree tears and episiotomy is quite common, and it does heal very well without any long lasting effects. But third and fourth degree tears do have a long term consequences, and it's very important that we recognize them, treat them very well, follow them up, and obviously follow them in future pregnancies so that they don't cause any long lasting term effects. So we follow the RCOG guidelines here, and so RCOG has developed a obstetric anal sphincter injury care bundle, and we have used this as a basis of our quality improvement project program, and in terms to prevent these injuries at the first place. So as I was discussing, the objectives where we are being a quality improvement task force in University Hospital Birmingham, and the aim is to ascertain and ignite awareness about OSS, its risk factors, and OSS care bundle. We also sought to improve adherence to guidance provided by OSS care bundle to prevent morbid perineal injuries. So the intervention is a three-tier intervention where education campaign, which consists of displaying posters, we did in multiple areas, in our clinical areas like antenatal clinics, in the labor ward, which actually one of the major place we wanted more awareness in, because quite amount of midwives don't do clinics. So labor ward with information of OSS, the risk factors, and the OSS care bundle. Then we emailed e-posters to the junior doctors and the midwives. So we also made sure that the OSS guideline of a trust was upgraded, and we incorporated the OSS care bundle to improve the awareness in midwives and junior doctors. So we also developed a patient leaflet on this information. So the women who are coming to antenatal classes and visits do have some amount of understanding as to what kind of perineal injuries can happen, especially in the first time mothers. So the design is it's a simple QIP which involves before and after. So a before and after retrospective descriptive cross-sectional study was taken, and the impact of intervention on knowledge of junior doctors regarding OSS. While we also discuss a little bit more in terms of definition, what is the classification, what are the risk factors, and what are the determinants of OSS care bundle and improvement, and how do we can improve it. We also assess the rate of OSS in our trust. We have three hospitals, but two hospitals basically deal with maternity delivery suite, and that is Good Hope and the Heartland Hospital. So we did study the OSS in these two hospitals. We have a collective delivery of 8,500 deliveries a year, including the normal deliveries and cesarean sections. So going on to results, this is prior to intervention. We looked into the awareness of OSS care bundle among junior doctors and midwives, and we found that it was 45% in junior doctors, and in midwives it was 52%. And the implementation was around 47%. Understanding what care bundle is different than when we implied in practical knowledge, I guess. So there was a difference in these, and we could see that the implementation was around 47%, and the use of episiotomy was found in 35%. So after an intervention, the awareness increased from 90% and implementation is improved to 86%. So as I told previously that we did different types of awareness. Previously, we took a feedback from all the midwives and junior doctors to see that what was the as in terms of what was their understanding, what are the measures which we can take, and what are the risk factors we have to look into the women, and obviously what are the measures we should take during the delivery, and encouraging the women, trying to reduce the instance of instrumental deliveries, and especially in terms where the maternal exhaustion or the maternal urges to push has reduced. Obviously, epidural also was a reason, but we try educating the women during the labor that what would be expected when they are fully dilated and need to push. So going on, these are also come up results that the rate of second degree tear was decreased from 42% to 35%. So obviously that was doing a very good impact, we felt. And we also looked into the instance of third degree tear. So prior to applying the care bundle, the instance was 2.5%, and it reduced to 1.5%. As such, our national values are much higher than this, and the fourth degree tear remained at 0.2%. Then use of episiotomy was also found to be in 35%. So I've just done a quick graph on the right side to show the instance of these tears and what was it before intervention in the yellow bars, and the purple bars show after intervention. So after conclusion, so implementation of any preventive scheme needs awareness among the clinician, and it also needs, the OSs also need a genuine obstetric concern, and it's a possible solution with no added financial burden to the healthcare. So if doctors and midwives are well aware of the impact of this, then it's a very well versed situation where we can improve the outcome in these women. So just a minute. I think we have just moved some slides. Yeah. So I did discuss about the intervention, that displaying what intervention was done and the design of my study, and the results of this study as to how the results were impacted in this study, and what was the conclusion of this study, and they this did help into the improvement of OSS tears in women, and yeah, pretty much that's the thing. This is a very small study which is done on QIP, and I'm open for any questions if anyone want to discuss.
Thank you, Dr. Nusharat, for your wonderful presentation. Does anyone have any query?
Thank you.
Hope there are no queries. Thank you once again, Dr. Nusharat, for your wonderful presentation. So we move on to the next presentation. Next presentation is a poster presentation by Dr. Lakshmi Jairaj from the Wrexham Miller Hospital from United Kingdom. Hello, Dr. Lakshmi Jairaj. Are you ready with your presentation?
Hi, hello. Yes, yes, I'm ready.
Okay, so I'm making you the presenter. Please click on the share button to share your screen.
Is it all right?
Yeah, is it possible to make it a full screen? Yeah, it's perfect.
Yeah,
Please
okay.
go ahead.
Thank you. Hi, everyone. My name is Lakshmi Jairaj. So I am a registrar of Gynae in Wrexham Hospital. So we are North Wales, United Kingdom. We belong to the Betsy Calder University Health Board in North Wales. So this is just a case report on one of the patients that we have encountered. I would like to thank my co-authors as well in this, Dr. Sujiva Fernando, Aniti Fernando, Lucy, and Dr. Haida Wasim as well. So I will go ahead with the case presentation first, and then we'll have a small discussion about what has happened. So this is a 23-year-old lady who was initially seen in the urology clinic with a history which is neither fitting for a stress incontinence or an urge incontinence. So she presented basically for incontinence, but there was no clear history of both.
There was also no clear history of continuous incontinence per se as well. So it was quite challenging in the history aspect, starting from the history aspect. She had an unremarkable ultrasound scan because, first of all the basic investigations that we do, they have done that, and they didn't find any abnormalities with it. They even did the urology department has also done a cystoscopy, which they found didn't find any abnormalities, and they also did a bilateral retrograde and video urodynamics for her because of her incontinence, and they couldn't clearly demonstrate any incontinence in those tested. She received empirical treatment. So first of all, she received physiotherapy for her symptoms. It didn't work. She also had anticholinergic medications, even intravesical botulinum toxin type A injections as well. So none of these helped her, sadly. So she was also referred to gynecology to discount a cause of a persistent vaginal discharge. So an examination in the gynecology department revealed a small dimple in the anterior vaginal wall, and it was queried to have either a fistula, which is congenital, or it can be a double urethra even. And she was getting prepared for further investigations, but unfortunately she was lost to follow up because she decided not to have any further investigations and not to have any further treatment. The patient, after 5 years, have gone to the GP again with the similar symptoms, and this time the GP has referred directly to the tertiary center. So the tertiary center review, they did, first of all, in the clinic, they did a vaginal examination by speculum, and this time they could find out that there was clear urine which was leaking out from one area of the vagina, from the vaginal introitus, and the leaking was seen through the left fornix. And therefore, it was identified and queried as either as an ectopic urethra or an ectopic ureter. So because of that finding, then focused investigations was done. Then they did an MRI urogram and performed, and the MRI urogram has found out that there was a left kidney with a duplex system and a prominent small upper pole moiety callus and parenchymal thickening. And there was an ectopic ureter which was draining into the left side of the vagina. Along with that, there was no other congenital abnormalities was found in the urogenital system. So, as we all know, ectopic ureters are they are actually well-established cause of incontinence. So they can actually drain anywhere. So preferentially when we say that it's an ectopic ureter because they drain outside the urinary bladder. So it is very rare, and it is about 0.05 to 0.025% of population, and it definitely has a female to male has a female preponderance because it is about female to male ratio is 2 to 6 to 1. So the most common sites for the insertion of the urethra is insertion of the ectopic ureter inserting into can be either into the bladder neck or the upper urethra. It can be into the vagina. It can be even into the uterus and cervix. So depending upon where it actually inserts into or where it actually drains into, the patient will have different symptoms. So if the current patient actually drained into the vagina, and that is why she had incontinence symptoms. So we did an extensive literature search to find out whether there has been cases before. So we did find some cases, but we found that everybody had a diagnostic challenge because the symptoms vary depending upon the site of exit. So most of the women usually comes to the gynecology department. We do basic investigations. Obviously, it will not be clear in basic investigations. Then we'll sidetrack the investigations towards incontinence, and they go ahead with the urogynecology investigations, all sorts of things. And usually in incontinence, we don't do CT or MRI because it's not investigation for an incontinence. So, and that proves to be a diagnostic challenge because we will not be able to know what is the reason. So we have come forward. So during our literature search, we have read about cases there where patients had ectopic ureters draining into the cervix and even into the uterus. So those patients usually present with heavy menstrual bleeding. Some people do have leakage or foul-smelling discharge all the time. So, and a couple of cases where it is draining into the vagina, where patient presented with similar symptoms like continuous incontinence. So in most of the cases, it was in some of the cases there was associated urogenital abnormalities like presence of a ectopic kidney along with the ectopic ureter. And most of the cases, as I said, we did investigations like transabdominal ultrasound, transvaginal ultrasound, which is usually not diagnosed, and was only diagnosed with focused investigations like CT and MR urogram. So about the treatment, a little bit about the treatment for ectopic ureters. So they have surgical treatments. So ureterostomy is a surgery which creates a new connection to correct the problem. So it can connect the ectopic ureter to a normal one. Then ureteral reimplantation means we can actually this surgery attaches the ureter to the correct position. So you can actually remove the ureter from wherever it was draining to and then reattach to the bladder. Then ureterostomy and nephrectomy in case of like if there's an ectopic kidney is also present. So in a nutshell, the learning points from this. So whenever a patient presents, particularly in a very young age group, where patients doesn't have risk factors for incontinence, and when a fistula query cannot be like justified because a patient doesn't have risk factors for a fistula either. So the obstetrician gynecologist should maintain a high index of suspicion to diagnose an ectopic ureter. I know that it's a very rare thing to happen, but for people who fail all the investigations and treatment, we can obviously sidetrack to this diagnosis. And a multidisciplinary approach, including a radiologist, urologist, and gynecologist, is necessary, and for investigation as well as to treat this condition. That's all about the poster. If you have any questions, please, I'm happy to answer it. Thank you.
Thank you, Dr. Lakshmi Jairaj, for your wonderful presentation. Does anyone have any queries? All right, hope there are no queries. Let's move into the further presentation. The next presentation is a poster presentation. Is by Dr. Nusharat Inamdar from the University Hospital, United Kingdom. Hello, Dr. Nusharat. Are you ready with your presentation?
I have already done my presentation previously.
Yeah, actually, there is a poster presentation, right?
Yeah, there was a poster presentation. I thought I did that previously.
Okay, so your presentations are over. Am I
Yeah, yeah.
right?
I have a pending one, but presently I'm just moving to theater, so I won't be able to stay for longer. That's why.
Okay, thank you. Okay, so by this, we come to the end of day one's webinar. I would like to thank all the attendees and participants of today's webinar. Hope you enjoy the webinar and gain knowledge from the sessions, and request you to attend tomorrow's sessions too. If you have any queries, you can mail to the concerned program manager. Thank you everyone and have a great day.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you everyone.